Okay, good afternoon, everyone. I'm Don Metz, Health Affairs Interim Editor-in-Chief, and I want to welcome you to today's briefing featuring work from the September 2025 issue of Health Affairs, which is a theme issue on the topic of the opioid crisis. The opioid epidemic was declared a national public health emergency in 2017, and we know that there are many causes of the epidemic, including the overprescription of opioids, in part due to misleading marketing, along with the difficulty of finding alternative medications for treating chronic pain. Several related trends add to the complexity of managing the epidemic, including the rising rate of overdoses during the COVID-19 pandemic, many involving opioids, unequal access to prevention and addiction treatment, and the rise of synthetic opioids like fentanyl. Given the public health implications and the many policy challenges around the epidemic, we're pleased to bring you a range of panels today featuring discussion of research and policy strategies covering prevention, harm reduction, treatment, and recovery support. And before moving on to those presentations, I do want to note that theme issues are very complex undertakings involving hundreds of contributors. So I do want to start with some acknowledgments. First, our advisors, Pooja Lagasetti of the University of Michigan and Brendan Salinger of Brown University. They helped us throughout the entire process, and we're very grateful to them for that. They have a jointly authored paper in the issue, and both will be participating in today's briefing. I also want to thank the staff of Health Affairs. Theme issues always require a great deal of teamwork, and I want to thank the staff for all the planning, hard work, professionalism, and creativity that it took to produce this theme issue. Of course, we want to thank the authors whose work will be discussed here today, our outside peer reviewers, as well as those who participated in our planning meeting in October of 2024, which we always start our theme issue process with. We thank all of you. And of course, we want to thank our funders, the Foundation for Opioid Response Efforts, for Dogwood Health Trust, Kaiser Permanente, and Vital Strategies. We're very grateful to them for their support of our work, not just the financial support, but for being true partners in the entire effort. Before I introduce our first presenters, let me just note that questions may be submitted through the Q&A tab at the bottom of your screen. Guests do not need to wait until the Q&A period to type in questions and should feel free to enter them in the chat at any time during the sessions. And moderators will field those questions at the completion of the presentations. So on to the presentations. In addition to the research, analysis, and commentary that our theme issue presents, we also include interviews, personal stories, and poetry. And we will begin today with two poetry readings, one each from Kaya Renouf and Carrie Fisher. We'll start with Kaya Renouf. Kaya is a clinical project manager at California Bridge, which is an initiative of the Public Health Institute's Bridge program. Kaya?
Hi, thank you so much for having me. So my piece is called To the Best Friend Who Gave Up on Me 20 Years Later. The first time I felt discomfort with you was the day we didn't want to play pretend anymore. We couldn't find the story and nothing happened. We picked a movie in uneasy silence, uncertain of what we had lost. I used to nourish my hatred for you every day, a meditation on my own unhappiness. Now I have lines around my eyes, and I love the idea that we could sit side by side at the bar and not know each other. But I suspect I would always know you. I have dreams sometimes where you listen to me. Sometimes we fix it and sometimes we don't, but we decide together. We parallel park instead of crashing and burning, which is how, even in that moment, I know it's a dream. I wonder how you take your coffee, if you even drink coffee, and which colors you've dyed your hair at 2 a.m. Who was the first person to break your heart? You or mine? Who do you text to see if the jacket is cute? I wonder what they feel safe telling you, given the limits of your love. Here's the truth, not that it matters now. You've missed the best parts of me, or another way, I've become my best self in your absence. Here's the truth, for what it's worth. I wish I could recall the exact date when I no longer knew your phone number by heart. I would celebrate it every year. Thank you.
Thank you. Thank you, Kaya. We will next hear poetry from Carrie Fisher. Carrie is Health Information Management Quality Analyst at University of Florida Health. Carrie?
Thank you. My poem is called You Found Your Home There. You found your home there with the weeds and the rocks. You found your people, yourself, you thought. You found the sickness had a name. It has a name and a voice. It has a presence and a goal, but you've always had the choice. I found you there in that place you chose to stay. The fire gone from your eyes, the others, many others, so close but far away. The pain you chose, the life you wasted. Time marches steadily on and on. You as if a statue. In that home you found yourself. A portent, a warning, a lesson, a moral, immoral. They flew how they flew. We flew. We thought we knew. All of our will, all of our desires, thoughts, dreams, feelings, cries, sucked into a void. That place you chose to stay, with the rocks and the weeds, with the pain and the stigma that derides and cleaves. That void you call a heart or a body or a home. That void you call yourself. It is you and you alone. Initially, a choice. Presently, no chance. No chance for change, damaged goods. Stay in your hovel, for the world does not want you. I found you there. I found you there, and there you will stay. Thank you.
Thank you both, Kaya and Carrie, for reading the readings and for sharing with the group. We really appreciate it. We will now move to our first panel. We're delighted to have several guest moderators today, so I'll turn it over now to Karen Scott and Ken Shatkes. Karen Scott is president of the Foundation for Opioid Response Efforts, and Ken is program director there. Karen?
Great, thank you, Don. And thank you, Kaya and Carrie, for launching today's event in such a meaningful manner. It's a lot to take in. So on behalf of the Foundation for Opioid Response Efforts, or FOR, and my co-funding partners at Dogwood Trust, Kaiser Permanente, and Vital Strategies, I also want to congratulate the Health Affairs editorial team, the theme issue advisors, Dr. Soliner and Legisetti, and all of the accomplished authors who have contributed to this special issue. FOR's mission as a national health philanthropy is to support evidence-based, patient-centered solutions to the opioid and overdose crisis. I think you will find that the content in this issue really reflects the ongoing value of scientific inquiry using different methodologies and data sources, along with the power of convening a broad range of thinkers to help inform strong policy solutions. So to get us right into the discussion, I am pleased to introduce this first panel examining geographic and system challenges in the opioid crisis. Our presenters are Brendan Soliner, Professor of Health Services, Policy and Practice at Brown University, Gervais Grooms, Associate Professor of Economics at Howard University, Rosalie Liccardo-Pacula, Elizabeth Garrett Endowed Chair in Health Policy, Economics and Law at USC Price, Yashaswini Singh, Assistant Professor of Health Services, Policy and Practice at Brown, and Travis Donahoe, Assistant Professor of Health Policy and Management at the University of Pittsburgh. The question and answer session following the presentations will be moderated by Dr. Ken Shatkes, who's program director here at FOR. And I'm pleased to turn it over to Brendan.
Great. Thank you so much, not only for having me today, but also for all the partnership in this amazing theme issue. Okay, thank you. So this is a piece jointly written with Pooja Lajasetti. And it's an overview piece for the theme issue, and I just want to walk through some of the thoughts that we had in writing this. So we start with the observation that there is persistent underuse of effective care in our opioid crisis. Most of the people who could benefit from treatment and harm reduction programs still don't use those services. National data vary, but about 1/4 of people with opioid use disorder are getting treatment. That means that many, many people are still not getting treatment with effective medications. Many people with opioid use disorder likewise are not carrying naloxone and do not engage with harm reduction programs. These are not new interventions. They've been around for decades. We've had really substantial federal and state investment around expansion of these services. And we also just note in our piece that there are incredible innovations in how to deploy these tools, whether it's street outreach teams, vending machines, mobile crisis units, all these kinds of promising models. They just don't exist in a way that is widely available for people who could benefit. And we want to draw attention to the scaling problem. Scale, as we define it, is the reach of interventions across disparate systems and areas. We sometimes talk about access to care, and that's very related. It's another side of the same coin. It's the ability of people to engage with the services that they need. But we really want to talk about scale now because it's a way to start thinking about what we call the production function. So specifically, how can we take the people, the money, the medicines, and get those inputs to achieve the desired outputs, which is more services for more people? We point out that scaling has both technical and sociocultural dimensions. We just can't engineer our way out of it. We have to understand some of the deeper determinants of why interventions are not scaling. And so we talk about technical barriers to scaling. We note 3, program complexity. Many programs require a lot of touch points with caseworkers, clinicians, therapists, and peers, bringing together different systems and different points of funding. That's clearly one barrier. There's also financial constraints. So substance use services have for a very long time been siloed from general medical care. They've existed outside of insurance-based reimbursement. And that's a problem because structurally it means that it's very difficult for the system to absorb outside funding, even with time-limited infusions of funding that have come from the federal government. So just being able to use those resources to achieve the outputs, that requires infrastructure that has not always existed. Regulatory burdens, particularly around the medications for opioid use disorder. We have a complex warren of federal regulations from DEA and SAMHSA, and then states have their own regulations, and sometimes there's even local regulations. And these are also an impediment to services operating and thriving. Next, we talk about what we describe as the sociocultural barriers to scaling. And here we also look to 3 factors. One is this really important observation that there's a problem of getting people to want treatment. So many people with active addiction are not seeking services, or they say they don't need them. Only about 1 in 10 report that they would like treatment. And we do note, and we think that it's very important to emphasize that stigma is part of the story, but it's not the only factor. And we need to look at other reasons why people are not demanding services, whether it's a cultural mismatch or a lack of convenient options. Likewise, stigma plays a role in community opposition. Many communities do want help, but they don't want scaled up services, particularly in the low threshold model. Some neighborhoods are understandably concerned about becoming magnets for people seeking services. And there's also, we need to recognize different levels of enthusiasm for low threshold services. Many communities still want to use more kind of tough love tools. We think that that's a real, genuine, thorny question that we need to start grappling with. And then at a broader scale, there's national dimensions to this. The Trump administration is putting into turmoil a lot of the foundations of our public health systems and services. And so while there's some support from the administration for the medications for opioid use disorder, naloxone and fentanyl test strips, other harm reduction models are under attack right now, and we need to just understand how that presents a barrier to scaling. We can solve the scaling problem. We need to build support and to look to a broader coalition of groups that would have an interest in the scaling agenda. And if you read our paper, you can see how we're thinking about that. When programs reach scale, we will be able to see their benefits, and that will in turn make them more legitimate to the public. But we do have a legitimacy challenge to overcome. Thank you so much.
Hello, thank you all for joining us. It's a pleasure to be here. Today I'm going to discuss, I'm Jave Grooms, by the way, at Howard University. I'm going to discuss geography and fentanyl, explaining the disproportionate rise in opioid overdose deaths among Black Americans. This is co-author work with David Powell, Don Hahn, myself, and Rosalie Pacuya, who you will hear next, discussing another paper next. And so we think of the opioid overdose as kind of three main waves. The first being in the 1990s when we saw a rise in prescription opioids. Then 2010, we saw a rise in overdose deaths. Can you please click the button next 2 times? And then the focus of this paper is this wave 3, which started in 2013, which we saw overdose deaths and increase in synthetic opioids. And so you can see the purple line and the black line kind of coinciding, and the trends very similar. The opioid crisis in the US has transformed dramatically over the past 2 decades, largely prescription driven to lethal contaminated illicit drugs. Next. Simultaneously, we've seen opioid-related overdose deaths by race and ethnicity change over time. And this is sort of what's driven this research project. So before 2010, overdose death rate was highest for American Indian or Alaskan Native, as well as white populations. And then after 2013, which is that wave 3, overdose rates increased sharply across all racial and ethnic groups, but it was especially high for Black Americans, where we see towards the end, 2019, 2020, it being up there as one of the highest overdose death rates. And so that the Black American overdose death rates would be that gold line. And so you can see right at 2013, the trend and the slope of that line starts to get steeper. Next, please. So changes in the drug supply have coincided with shifts in the demographics and geographic distribution of overdose deaths. Next. And so what we're trying to look at, or what we are exploring in this paper, is how does geography help explain the increase in opioid-related overdose deaths among Black Americans? And so in doing that, we started to think about where are we seeing these overdose deaths? And we saw a trend happening. And so the Great Migration, 1916 and 1970, we saw a migration and settlement patterns for Black Americans affected by a variety of issues, from historical policies such as redlining, Jim Crow, sentiments of slavery. So before the 1900s, we saw that 90% of Black Americans lived in southern states, mostly rural areas. But by the 1970s, 80% of Black Americans lived in urban cities. Most substantial increase was in the Northeast and the Midwest. And so this paper is really exploring this phenomenon of changes in geography and what we're observing with the fentanyl overdose deaths. Next slide. And so using mortality data, we are able to identify overdose deaths by substance type, and using data from the last 2 decades, we're looking at opioid-related drug overdose deaths per 100,000, and we're looking at it by county, racial, ethnic group, and year. In our paper, we also assess this including and excluding cocaine, which would include cocaine varietals like crack cocaine. So we use the data to estimate the share of overdose rate growth attributed to the geographical spread of the crisis. Next slide, please. And so prior to 2013, as you see in the visual representation to the right, prior to 2013, the fentanyl era, we saw small racial ethnic differences, right? So we see most of the differences across race very, very similar to 0, not very different than 0. Then the onset of wave 3, the fentanyl era, we see it starts to deviate. So in 2020, geography explains an additional 3.2 deaths per 100,000 relative to the mean for Black Americans. Next slide, please. So overall, our findings, we find that prior to 2013, geography contributed little to racial ethnic overdose disparities. But with the onset of wave 3, we found geography became an important factor during the fentanyl crisis. From 2010 to 2020, roughly 40% of the growth in Black opioid-related overdose deaths versus white overdose deaths was attributed to differential geographic exposure to the fentanyl crisis. And nearly 80% of non-cocaine related opioid overdose deaths among Black relative to white was attributed to geography. So in conclusion, new demographic patterns highlights deeper changes in how illicit opioids are assessed, and the structural inequities shaping substance use behavior and treatment opportunities. Geography is a key driver of racial disparities in opioid-related overdose deaths since the onset of the fentanyl crisis. And policies that fit an earlier wave may prove inadequate when faced with new landscape where fentanyl dominates. Next slide. Thank you. Up next, Rosalie Peculia will present a paper.
Thank you so much, Jave. It's really an honor to be here with all of you and presenting the key insights from our paper. That is really work that was done by me and a broad team of researchers who are part of the RAND USC Schaefer Optic Research Center. Next slide. The concept behind this paper release arose from a very simple observation, and that is, despite a large empirical body of evidence examining the impact of a whole bunch of different opioid policies, there was a lot of contradictions and inconsistent conclusions about the impact of specific policies, in particular prescription drug monitoring program laws, naloxone laws, and even medical marijuana laws. And while it's not unusual for scientists to generate some different findings and inconsistency, it turns out in most of the instances in this literature, the problem was not because science was generating inconsistent findings, but it was that the science wasn't actually replicating the studies the same way. They were looking at different data, different measures, and using different approaches. And those differences generated results. So many of the inconsistencies were actually artificial, not real. In the meantime, the opioid crisis was killing at a rate of 70,000 lives per year, particularly in the most recent years. And policymakers, confused by the inconsistent findings in this literature, resisted adopting evidence-based effective strategies. Next slide. So the purpose of this paper was really to try to help researchers more effectively communicate to each other and policymakers their findings by doing two things. First, we wanted to offer a uniform framework for approaching and presenting opioid studies so that we could improve the state of knowledge across the range of disciplines contributing to this important literature and increase the pace of science. But second, we thought it was important to discuss why the presentation of data, outcomes, methods, and mechanisms of action concretely was particularly important for the opioid policy space. And it boils down in the second point that the simple fact is that the policies tackling the opioid crisis are as diverse as the disciplines who are studying it, and the impacts a variety of different social systems, from healthcare system, the welfare system, employment, and even criminal justice system. Next slide. So our proposed framework for communicating when you're a researcher in this space, particularly publishing in multidisciplinary journals, is first to articulate the causal model in a non-technical language. Second, carefully consider and communicate the extent to which your study design, your selected outcomes, the policy measurement, the sampled population, and the setting in which you're evaluating all of these things is accurately capturing the mechanism of action that you're trying to investigate, or simply approximating it and communicating that clearly. And then third, describing why the empirical model you're using is appropriate for identification of causal effects when that's the case, because while it might be clear in your own discipline, it might not be clear in others. Next slide, please. I don't have time to go into each of these, but what I'm going to talk about was the first one, or the second one, the construct validity, and just raise a few key points with regard to a couple elements of construct validity. First, outcome data and measures. And here we wanted to emphasize three things. First, opioid policies affect multiple populations, both within and outside of the traditional healthcare system. Thus, analyses using claims data can only paint a partial picture of who is in need of treatment and who's actually getting it. And this is because care can be received in other settings, including the criminal justice setting. And policies aimed at influencing access to treatment in one of these populations can differentially influence other populations. And that's legitimate. That's not an inconsistency. That's just heterogeneity that's natural across this policy area. Second, insurance status of those receiving treatment impacts where they access care, as well as the care received. And while this is a simple concept for those of you who work in the healthcare claims data all the time, it's not as simple for those who work in other administrative data systems and needs to be made explicit. And then third, clearly articulate the mechanism of action and target in the data that you're actually analyzing. So people who are less familiar with that sort of data setting can put your findings within context. Next slide. The second part of this is thinking about the policy itself, and in particular, two things. First, states adopt multiple strategies over a short period of time, and that can lead to lots of confounding or synergistic effects of the policies on the given outcome. And then secondly, that individual policy that you're interested in studying may change over time and be modified and become stronger. So later studies on modified versions are not necessarily the same study as of a study evaluating the first version of that policy. Next slide. So to conclude, we have 4 simple takeaways. I don't have time to go through. I offer them here for the viewers, but if you're interested, please take a look at the paper. And next, I'd like to turn the mic over to Yashwini Singh to talk about the results in her paper. Thanks.
Hi, everybody. My name is Yashaswini Singh. Thank you so much for the opportunity to share our paper and for including this paper in the theme issue. The main finding of the paper is also the title of the paper. Private equity firms are acquiring large shares of the opioid treatment market without changing market level methadone supply. This is joint work with co-authors at Rand, Brown University, as well as the University of Pittsburgh. Next slide, please. Now, as we know on this call, the opioid crisis is a national public health emergency in the United States, and we likely also know that methadone is a highly effective treatment that can cut overdose deaths by more than half, yet remains underused. One reason that methadone is underused relates to the difficulty of accessing treatment, as we've already heard today. And one reason access to methadone remains restricted and uneven is in part because methadone can only be dispensed at present at opioid treatment programs, or OTPs, of which there are about 2,000 nationwide. As a result, in recent years, expanding access to methadone has been a major bipartisan policy focus, with legislation introduced to expand not only where methadone is available, but also who can prescribe it. Now, many experts agree on the importance of expanding methadone to address the opioid crisis. And at the same time, policy reform has faced some opposition from for-profit entities who anecdotally appear to be affiliated with private equity firms. Next slide, please. PE firms are financial firms that in recent years have been drawn to many healthcare settings in the US. One recent study estimated that about 30% of opioid treatment programs in the US are currently affiliated with PE firms. If we take a step back and think about what we might expect from private equity, there are a couple of characteristics that warrant closer attention. First, PE firms often rely on large amounts of debt to acquire majority investment stakes. Second, PE firms often rely on platform and add-on consolidation, raising concerns about increased market power and increased market concentration, as well as reduced competition. And finally, PE firms tend to have a short investment horizon, and so they tend to focus on rapid investment returns over longer-term investments in care quality or stability. Now, proponents also argue that private equity investments might bring capital infusions into the addiction treatment space in ways that can address current shortfalls in public funding. At the same time, critics argue that PE investments in OTPs will merely result in a consolidation of ownership of these facilities among a few financial firms without expanding access to treatment. Next slide, please. This fundamental tension has been the concern and the subject of multiple federal investigations, including one announced just last week after I prepared my slides, so they're not highlighted here today. But if you're paying attention to the news, you might have seen that in 2024, US senators launched a bipartisan inquiry into PE's role and influence on opioid treatment programs. In a letter sent to PE-affiliated OTPs, they questioned why PE firms are resisting reform to expand methadone access. I quote, "There is an incompatibility manifesting itself in PE-backed OTPs seeking to maintain their monopoly on methadone access, not because it is good for the patient, but because it is good for the bottom line." Next slide, please. PE firms have responded, denying claims that PE has negatively impacted the OTP landscape, claiming that PE firms generally reinvest profits to build new clinics and see additional patients, implying that this might lead to an expansion of treatment access. Next slide, please. Amid this policy and legislative backdrop, the fundamental question that remains unanswered from our perspective is whether PE firms are expanding access to methadone or simply consolidating ownership into the hands of investors without improving access, which also is our specific research question for this study. Next question, please. To answer this question, we combine data on PE acquisitions of OTPs combined during a variety of sources, including data from PitchBook compiled with manual validation. We combine acquisition data with facility-level data on methadone shipments released as part of a multi-district opioid litigation. Next slide, please. We link these datasets using geocoded facility addresses, and our primary empirical approach for this study is a stacked event study regression that compares differential change in the outcomes of interest for our study at PE-acquired OTPs relative to a comparison group of OTPs both before and after acquisition. Next slide, please. We identified over a 10-year time period about 358 acquisitions of opioid treatment programs by private equity firms. We also document the expansive scale of consolidation at play. In counties with any private equity activity, PE firms control about 2/3 of opioid treatment programs. We also document the presence of a few key platforms that dominate the opioid treatment program market in several states. Next slide, please. In difference and differences analysis, we found that methadone shipments to PE-acquired facilities increased by 13% following acquisition. But importantly, this increase was not statistically significant after adjusting for pre-existing trends, as you can see on the blue dots on the figure. This suggests that methadone supply did not change as a result of the acquisition itself differentially from OTPs that were not acquired by private equity firms. We also estimated a 4% decrease in methadone shipments at competing facilities or facilities that were exposed to private equity investment in the same market, but not directly acquired. Once again, this decrease was not statistically significant. Next slide, please. In secondary analysis, we examined whether PE acquisitions resulted in the openings or additional openings of new OTP facilities in the market, and we did not find any significant changes to the number or existence of OTPs operating in a county. Next slide. In addition, we found no changes to the county-level methadone shipments, in addition to no changes to facility-level methadone shipments documented earlier. Next slide. And finally, we did not find any changes to county-level opioid overdose deaths. Next slide, please. So in sum, I wanted to request you all to check out our paper because there's a lot more careful, rigorous empirics that I'm unable to touch upon today in the time allotted. But I want to emphasize our key takeaway for the study, which is that private equity acquisitions have an expansive presence in the American healthcare system and have recently turned their focus to the addiction treatment landscape. Our study shows that acquisitions of OTPs by financial investors result in a concentration of ownership of OTPs among a few financial firms without necessarily expanding methadone supply. Given this, we think that additional scrutiny of the role of PE investments in addressing the opioid crisis are warranted. Thank you so much for your time and attention, and I'll now pass it on to my co-author, Travis Donahoe.
Hello, everyone. My name is Travis Donahoe, and I'm at the University of Pittsburgh. I'll be presenting this paper about restrictive state opioid treatment program regulations and how they affect access to methadone maintenance treatment. This research is joint work with several co-authors at the University of Pittsburgh as well as New York University. Next slide, please. So as Yashaswini touched on previously in the last presentation, methadone is a really effective treatment for opioid use disorder. In a recent review by the National Academies of Sciences, Engineering, and Medicine, it was found that methadone has the potential to reduce overdose mortality rates by about 50% among people with opioid use disorder. However, unlike the other two main medications for the treatment of opioid use disorder, supply of methadone is really uniquely heavily restricted in the United States. And these restrictions date back to the 1970s, with patients who have opioid use disorder and want to obtain methadone treatment being required to obtain treatment from federally certified opioid treatment programs, from which there are only about 2,000 nationwide. And unlike most other medications, it's not possible to go and obtain methadone from an outpatient clinic that's prescribed to you and then have it dispensed at a pharmacy. And as a result of these policy choices, relatively few people with opioid use disorder receive methadone-based treatment. Next slide, please. So in addition to the federal regulations, states can add additional treatment restrictions that go on top of them. And a recent review by the Pew Charitable Trust summarized different kinds of restrictions that states have implemented in recent years that span domains of access to services as well as barriers on patients receiving care. And so you can see some of these restrictions entail things like certificate of need programs that require opioid treatment programs to demonstrate that there's sufficient need for an additional OTP before opening in that area, zoning restrictions on where they're allowed to open a new OTP, and additional things that affect patient experience, like whether or not they should be eligible to receive take-home doses in the first 30 days, and what kinds of criteria they have to meet in order to be eligible for those. And you can read more about some of these restrictions in the paper. Next slide, please. So the purpose of our paper was to understand what effect these state opioid treatment program policies have on local access to methadone treatment. And to do that, we drew on a previously published study by Conway and colleagues in 2023, which took all of the policies that I just showed you on the previous slide and used latent class analysis to classify states as either having generally high restrictive policies or having low restrictive policies. And we linked that with two main measures of access. One was the probability that a zip code has any opioid treatment program. And the second was total methadone shipments to opioid treatment programs in a zip code. Both of these were measured in 2019. Next slide, please. And our study design compared zip codes that fell on opposite sides of state borders where policies changed from being highly restrictive to less restrictive. And the reason that we focused on these borders is that the policy environment changes really significantly as you go from a zip code in a state with highly restrictive policies just across the border into a state with less restrictive policies. But underlying treatment needs shouldn't really change that sharply across state borders. And just to provide some evidence of that, in the paper, we look at several observable determinants of opioid use disorder and underlying treatment need, like racial and ethnic composition, socioeconomic characteristics, and so on. And we don't really find large or significant changes in those observable determinants across state borders. And so this approach really allows us to isolate what effect these policies are having on local access. Next slide, please. And so we find that there are really, really striking differences as a result of these policies. So in this figure, it shows you the distance between miles to the state border where the policy changes from having high restrictiveness to low restrictiveness. And the vertical dashed line is the state borders. And the y-axis is showing the probability that zip codes within different bins of distance from those borders have any opioid treatment program. And we find that the probability of having any opioid treatment program doubles at the border of the low restrictiveness states. We find similar results in terms of increases in methadone shipments to opioid treatment programs. And these are really clinically significant changes, equivalent to about 8 to 35 more people receiving treatment over the course of a year in the average zip code in less restrictive states. Next slide, please. So just to conclude, we find evidence of really striking differences in local access to methadone treatment between states with more and less restrictive opioid treatment program policies. And this really suggests that easing some of these state policies is a viable strategy states could pursue to help more people get methadone-based treatment locally. Thank you again for the opportunity to present.
Hello, everyone. Ken Shaskis, the program director here at Forum. We're going to start a Q&A session now with our presenters. Thank you again for the very quick, I know, presentations. I got a lot of information in. So we do have a few questions in the Q&A box that we can start with. The one I really want to start with is because we spoke quite a bit on all the different things that we need to be doing around this, is given the limited resources and the difficult trade-offs that, around, some of these policy solutions, expanding access, reducing misuse, pain, and management. What roles do you see for data-driven decision support tools like optimization or prescriptive analytics in helping clinicians and overall just helping policymakers make the decisions that they have to and what we should focus on? So I'm going to toss it up, and who wants to start?
Brandon, you were not nodding first, so.
Okay, well, it's a tough question. So I've seen some really promising proofs of concept of how to use analytics in the opioid crisis. I've now moved recently to Rhode Island, which is a state that actually has been a leader in terms of dashboarding. Just before I got on today's webinar, I saw that the state had issued a overdose spike alert in one of the regions in the state. And that was an insight built on dashboard tools. So I think that there's ways to use the tools of analytics to actually guide policy because there's tons of information in the world that can be harvested in real time to guide decision making, whether it's EMS runs or numbers of patients in treatment, which we can track on a daily basis. We're in the midst of a data revolution, and I think that our field is going to reap the benefits in the next couple years. We're just not there yet. So I'm really bullish. I'm optimistic that we can use these kinds of tools to do a lot of good things. I just think that we need agile public health departments that are ready to respond when the data show where we need to go with resources.
And I think we also need scientists to be cautious in interpreting, helping the policymakers interpret them, because many of the dashboards are basically as good as the data feeding them, and certain communities are not feeding data into them, or certain populations are not feeding data into them. And we can't neglect those geographies or those populations just because the data is not represented. So I think it's really important to keep in mind, use the data. I think it's a tremendous tool, but keep in mind the limitations of the data when thinking about policy, because those omitted populations matter as well.
Well, that was going to be my next question, was around that data aspect and helping policymakers and understanding that their public health data right now is a little bit on the we're unsure about it at the moment. And I'm curious, Rosalie, from your perspective, how do we, one, what data do we use, and and how do we develop real policy solutions based on that and advocate that to policymakers?
I think there's some obvious data that we can use to get a glance at things, and many of us are using those data: the emergency department, the EMT response, the poison call data, even the drug testing data in a local community that's identifying a new substance that's showing up, or perhaps unsuspected drug just entering into a different drug chain. I think all of those are useful data sources, but we have to remember that things like emergency department data or poison call data are things that represent people who are willing to use those systems, and that's not everyone. That doesn't mean that nothing's happening in those other areas. It just means that people aren't reporting from those other areas. And this is going to be an increasingly larger problem going forward with the immigrant population in neighborhoods where there's lots of immigrant populations who feel threatened right now. They aren't going to report. And we need to be cognizant of that, because the problem happens everywhere.
Absolutely. And you mentioned disparities of vulnerable populations. This helps move us over to Dr. Grooms. I'm curious, you looked at the basically pre-pandemic, pre-COVID-19 pandemic data, and we know that since then that there's been even more disparities and a rise in overdoses among Black Americans. As we've entered really the fourth wave of a polysubstance crisis as well. So I'm curious, what your thoughts are about that. And do you expect that when we look at this data over the last 5 years or so, that we may actually see the problem actually have gotten worse, and how geography may play into that?
First off, thank you guys for this session. I think it's been great to hear the work by colleagues. I I think the answer is yes. I think some of what Dr. Sloman mentioned about access and scalable and kind of the different need for different communities might even be more exacerbated post-COVID. And when we think about the role that COVID and access to employment may also have played to exacerbate these disparities. So in short, yes, I think that we may see. We're still doing more work. This is one of many papers in this area that this team is working on. But I think, in short, yes, the answer is yes. We don't think that things got better during COVID. We think things across the board for most communities have gotten worse, and we think that it may be exacerbated for Black urban communities, particularly in the Midwest and Northeast.
Well, so I think again, expanding access is going to be really important. And one of those access points is opioid treatment programs. So I think we'll end with two questions, around OTPs. Dr. Singh, specifically around the private equity question. This is something that we've been, hearing about quite a bit over the past few years. And, it was really interesting your data that you showed around that, at least within those communities where they have that larger share that they've kind of moved in, you didn't see maybe the massive amount of overdoses increasing, maybe methadone not actually increasing as well. But were there any positives that you've seen at all in, I guess, private equity moving into there?
Thank you for that question. And again, I'll echo the thanks to my co-presenters on this panel. There have been instances of so-called benefits of private investment and private equity investment in general in healthcare. In the opioid treatment program landscape, ours is the first study that we're aware of that's attempted to look at outcomes following PE acquisitions. The findings of our study do not give much hope, but I'll also acknowledge that we only look at methadone supply as measured by shipments to facilities. There are other measures of access that are more patient-oriented that would be important for us to examine in future work. And I'm hopeful that with careful empirical inquiries into those questions, even if there aren't benefits that materialize, at least we would do a systemic, thorough job of asking those questions. And so I guess I'll say stay tuned for future work, because I think there are a lot more unanswered questions at present in this landscape than answers we have.
Yeah, I'd be very curious, on the question of, how much dispensing is actually happening as opposed to shipments. And I know that there'll be another paper around buprenorphine dispensing later. And Dr. Donahoe, my last question, you put all that list of different things that we need to work on, around the regulations aspect. That's a long laundry list. And I'm curious if you've identified, maybe the top ones that you think can really make a large impact by just policymakers focusing on those ones specifically.
Yeah, so it's a tough question. So one challenge with answering it is that they tend to be really highly correlated with one another. So the same states that have the certificate of need laws are the kind of similar states that have the zoning restrictions and the kinds of restrictions on patient experience. And so, because of that, it's empirically pretty difficult to disentangle. And one thing that we did in the paper is we have this analysis where we try to split by, is it the access restrictions or is it the ones that are like the barriers to patient experience? And we actually found really similar effects regardless of whether the state had a high cluster of these more access-oriented restrictions or patient experience. And so I think it really is about just generally this restrictive environment that's facing them and trying to understand which of those restrictions are necessary and which are not necessary and thinking about scaling the ones back that aren't
Mhm.
providing any benefits for patients or public health.
Well, I think we can potentially using the framework that Dr. Pakula actually presented around the policy solutions might be a good way to determine which ones are the best ones.
And
All right,
actually,
I think go for it.
there is another minute, so I think we can probably get one more in. And I see the last question in the Q&A is about what happens in rural areas, which I know is very much on everyone's mind in terms of concerns about even further healthcare shortages in rural areas. So, and Brendan, I think it comes back to your kind of questions around access and scale. But how does that look different in rural areas, and how do we work on that in areas where the numbers are low, the volumes are low, and we know the providers are already scarce?
Yeah, I think that's a great question. And what we mean by scale is going to have to be contextualized for rural communities in a different way. I think that we don't have a perfect playbook for how to serve rural communities. I've been doing a lot of work on one intervention, which is mobile medication units. And there was great hope that these vehicles would be scalable for rural communities. And actually, it's turned out that because of the regulations, they're very hard to get them out to some of the more underserved areas because there's no OTP miles away. So I think that without having a real geographic kind of benchmarking and a way of saying here are communities where we absolutely must find ways to expand services and making that sort of the imperative of policymakers, these communities will continue to be spatially underserved. And that's just one piece of it. But I think that, Travis's piece definitely speaks to some of the geographic disparities that we have yet to overcome.
Fantastic. Well, again, I just want to thank everyone for joining this panel and a great conversation right now. I'm going to hand it over now to Dr. Pooja Lagasetti, who is a faculty member in the Michigan Medicine Division of General Medicine and a research scientist at the Center for Clinical Management and Research at the Ann Arbor VA. Dr. Lagasetti.
Great. Thank you so much. I would love to start to introduce our next panel, which is titled Expanding Access to Opioid Treatment and Harm Reduction. I'll start by introducing all of our panelists up front, and then they will go on to present for a few minutes and pass the torch to each other. So first up, we'll have Lauren Kelly, who is an assistant professor of geriatrics and palliative medicine at the Icahn School of Medicine at Mount Sinai. Then followed by them, Dr. Elizabeth Samuels, Associate Professor of Emergency Medicine at the University of California, Los Angeles. Dr. Jenny Guadamus, Assistant Professor of Health Policy and Management at the University of California, Berkeley. Dr. Maureen Stewart, who is a Research Associate Professor of Health Law, Policy and Management at Boston University. And Dr. Lindsay Allen, Associate Professor of Emergency Medicine at Northwestern University. Pass it on to you, Dr. Kelly.
Good afternoon. I'd like to begin by acknowledging my co-authors from the New York State iPro, and I'd also like to thank the organizers of this special issue for this opportunity. Next slide. As the US population ages, we're seeing more and more older adults with substance use disorders, including opioid use disorder, who require care in nursing facilities, yet most facilities are not equipped to provide evidence-based treatment. For example, iPro data show that over 90% of nursing facility residents with opioid use disorder don't receive medications for opioid use disorder, such as buprenorphine and methadone, despite these being life-saving standard of care medications. Next slide. The literature also documents a pervasive pattern of rejection of patients with substance use disorders from nursing facility care. The drivers include stigma, lack of training and high staff turnover in nursing facilities, confusion around regulations, and financial disincentives, particularly for Medicaid-covered patients. Unfortunately, lawsuits and penalties for facilities in violation of the Americans with Disabilities Act haven't significantly changed these discriminatory practices. Next slide. This has real consequences. A recent study of Medicare patients hospitalized with opioid use disorder found that nearly 1/3 required post-acute facility-based care. So this is a sick population of patients with high comorbidity. And when nursing facilities refuse to accept patients, they remain in hospitals for days or weeks, leading to costly stays, bed overcrowding, changes in care plans, and potentially unsafe discharges. Next slide. In this article, we set out to do 3 things. 1, to cut through the confusion around the complex regulations that have discouraged facilities from treating substance use disorder. 2, to highlight practical solutions and innovations, and 3, to identify some of the broader policy changes to continue to support these efforts. Next slide. For our first objective, we felt that a succinct and clearly stated summary of the complex regulatory environment, particularly around methadone use in nursing facilities, was missing from the literature. We believe that a clear summary of these regulations can give policymakers, regulators, and nursing facility leaders confidence to build more capacity for care. Next slide. Our second and primary objective for this article is to highlight promising models across the US that are already working. Through stakeholder interviews with 16 national experts who are listed in the paper, we identified multiple innovations, including educational programs and policy toolkits that can be easily adopted by nursing facilities to reduce stigma, provide step-by-step protocols for implementation, as well as technical assistance programs funded by various mechanisms that offer hands-on assistance to nursing facilities as they integrate care for residents, and formalized collaborative care models that link hospitals, nursing facilities, and community addiction providers, including OTPs, to ensure medication continuity after discharge. Next slide. We also identified several exemplary nursing facilities who are leading with the development of comprehensive internal substance use programs and also hiring addiction-trained staff. Lastly, and we feel most promisingly, we highlight several state-sponsored efforts, including financial incentives, such as enhanced Medicaid add-on payments for facilities serving patients with substance use disorders, and other uses of funds to support care capacity in facilities, including mobile medication units. Next slide. Our third objective in this analysis was to outline broader policy changes to support and sustain these efforts. These include improving reimbursement for the full scope of addiction services. From the federal perspective, expanding Medicare coverage through the establishment of parity protections for substance use disorder care. From the state perspective, enforcing minimum standards for Medicaid programs, and more generally, payer support for models that integrate substance use care in nursing facilities, including the ability to bill for substance use services while patients remain in nursing facilities. Next, we need to remove barriers to life-saving medications. At the federal level, we need legislation or CMS ruling that removes prior auth barriers for buprenorphine. We need standardization of Part D coverage for evidence-based substance use disorder medications. And we also support increasing access to methadone via the proposed Modernizing Opioid Treatment Access Act of 2023 that was previously mentioned. Lastly, we suggest tying payment to quality measures that incentivize evidence-based care, such as incorporating substance use disorder measures into minimum data set, the minimum data set used by facilities, as well as the CMS 5-star quality rating system. And next slide. I want to close by acknowledging today's fiscal climate. So recently proposed Medicaid cuts will definitely make progress harder, but the cost of inaction is actually higher. Untreated substance use disorder leads to rehospitalizations, longer stays, worse outcomes. So it's ultimately more expensive. Addressing substance use disorder in nursing facilities isn't just the right thing to do. It's, we believe, a cost-saving necessity. And we hope to see renewed interest in a governmental task force or coalition to improve substance use disorder care, one that includes nursing facilities as an important site of care and recognizes the opportunities that we have. Thank you, and I look forward to the discussion. Next up, we have Elizabeth Samuels presenting her article.
Thank you, Lauren. My name is Liz Samuels. I'm an emergency addiction medicine physician at UCLA, and I am here to talk about work on behalf of my team here at UCLA and also with California Bridge. Next slide, please. So California Bridge is a statewide organization that's a project of Bridge, which works with emergency departments to do a variety of public health interventions, but one of the main focuses of their work has been expanding access to addiction treatment through the emergency department. The goal of California Bridge is to establish 24/7 access to high-quality treatment of substance use disorders throughout California. The goal is to do that by 2025, which they've largely have done. Next slide, please. Their model has three main components. One is low barrier addiction treatment with buprenorphine, connection to care and patient navigation in the outpatient setting with patient navigation, and which focus not only on substance use disorder treatment, but also addressing social determinants of health and substance use and recovery, and then promoting and instituting a culture of harm reduction, in addition to trying to change how care is delivered, providing access to naloxone through emergency departments for overdose rescue. Next slide, please. Implementation of California Bridge was multifaceted and a huge undertaking. So the state allotted grants, funding to California Bridge, which was distributed to hospitals who could apply to become a California Bridge affiliated site. Sites were funded to hire a patient navigator, support the time of a clinical champion, and provided training and on-demand technical assistance in treatment pathways, which hospitals would implement both with their staff to provide buprenorphine, is the example here, and patient navigation to patients with substance use disorders. Direct funding was provided to hospitals. There were 3 funding rounds. Our study looks specifically at the last funding round, which reached over 80% of California hospitals. Next slide, please. So in this study, we looked at hospitals which participated in the last funding round of California Bridge, which was from June 2022 to December 2023. But we also looked at buprenorphine prescribing among emergency physicians at all California hospitals using the CURES, or the Prescription Drug Monitoring Program database in California. This was a retrospective cohort study. We used data from program reported data, an aggregate from all of the sites, and CURES data. And our main two outcomes were provision of buprenorphine in the emergency department, which includes both dispensing at the time of the ED visit and prescribing, as well as patient navigation encounters. Next slide, please. So all of the hospitals that California Bridge worked with were able to implement the program with high fidelity. We did see some differences, though, in services provision at types of hospitals. So when we looked at navigators encounters, we compared provision of patient navigator, engagement of patients by patient navigators by public versus private, teaching versus non-teaching, and rural versus urban hospitals. So in general, we saw that public hospitals provided increased patient navigation to their patients compared to private hospitals. There was no significant difference between teaching and non-teaching hospitals. And then rural hospitals were less likely to have engagement by patient navigators compared to hospitals that were located in urban settings. Similarly, buprenorphine treatment provision, both dispensing and prescribing, was higher at public hospitals compared to private hospitals. No differences were seen in terms of teaching versus non-teaching hospitals and rural versus urban hospitals. Next slide, please. Navigators encounters during the study period, we looked at data from 252 hospitals in California. This represented over 165,000 navigator encounters. As I mentioned before, there was a higher monthly encounter rate at public hospitals compared to urban hospitals. This graph separates out navigator encounters based off of the round of funding that hospitals first started working with Bridge. So some hospitals had worked with Bridge for several years, starting in the first round of funding. There were about 52 hospitals in that first funding round. And then we had a second subsequent round, and then this last funding round, which is represented in red. So this is when they started participating with California Bridge. So what we see here is that hospitals which started participating in this last funding round had a rapid increase in provision of navigator encounters to patients with substance use disorders, becoming pretty much at the same rate as hospitals who started in round two. And we show a maintenance in navigator encounters over time among hospitals that were engaged in rounds 1 and round 2. Next slide, please. We saw a very similar trend for buprenorphine treatment provided. So again, 252 hospitals reported data, nearly 45,000 instances of buprenorphine treatment during the study period, and we had a significant increase throughout the study period and maintenance of services delivered over time. Next slide, please. We looked at the CURES data to look at buprenorphine prescribing at all California hospitals. This includes hospitals that participated in Bridge and hospitals not participating in Bridge. And we saw there were over 1,700 unique emergency clinician prescribers. This includes physicians, nurse practitioners, and physician's assistants. And so we saw over 6,000 buprenorphine prescriptions from emergency clinicians for just over 5,000 individual people. About half of these prescriptions were for treatment initiation, which means that people had not been on buprenorphine previously. These were new instances of treatment initiation. And then over a third of these prescriptions resulted in a subsequent buprenorphine prescription within 40 days of the emergency department visit. Next slide. So looking at this last round of implementation from California Bridge, what we really see is that has been previously demonstrated, California Bridge has successfully implemented emergency department patient navigation and buprenorphine treatment programs in diverse emergency departments across geographic and clinical settings, rural, urban, teaching, non-teaching, public, and private. And this has really been maintained over time. So there was an initial marked success with the initial rounds of implementation, but this has sustained. And I think this is really important because the emergency department, we are available anytime, anywhere for anyone. And it really marks an important opportunity to provide low barrier access to treatment initiation and may be a model for improving care nationally. I'm happy to take any questions in the panel. And I'd like to hand it off to our next speaker, Jenny Guadamuz.
Thank you so much. Hi, everyone. My name is Jenny Guadamos. I'm just a professor at UC Berkeley. And today I'm going to talk about trends in the availability of buprenorphine at retail pharmacies in the US. I want to acknowledge my co-authors, Dr. Sarah Axteen and Dr. Dima Cato. This study was supported by a grant from FOR. So let's get into it. So buprenorphine is the only scheduled medication for OUD that can be prescribed in the primary care setting and subsequently dispensed at retail pharmacies in the US. And there's tens of thousands of pharmacies in the US. It also plays a special role as a partial opioid agonist, and it's very effective at reducing the risk of overdose death. And efforts to improve treatment access to buprenorphine have really focused on addressing restrictive prescribing regulations, such as the 2023 removal of the X waiver. And what this means is that now any clinician authorized to prescribe controlled substances is also allowed to prescribe buprenorphine. However, these efforts to improve buprenorphine access have largely ignored the role of buprenorphine availability at pharmacies, the actual place of dispensing, which is what we'll describe today. Next slide. We use data from IQVIA longitudinal claims, which represents 93% of all prescription claims in the US. And availability was defined as a pharmacy that offered buprenorphine regularly. So at least one prescription dispensed each month in a specific year. Next slide, please. Buprenorphine availability increased marginally from 2017 to 2023. And currently about 39% of pharmacies in the US dispense buprenorphine. But what we saw consistently is that buprenorphine was less available in communities of color, where less than 1 in 5 pharmacies in Black and Latinx neighborhoods had offered buprenorphine regularly in comparison to nearly 50% of white neighborhoods. Next slide, please. As of 2023, the availability of buprenorphine at pharmacies varied substantially across states, ranging from about less than 25% in Washington, D.C., Iowa, Virginia, North Dakota, and Texas, to over 70% of all pharmacies in 6 states, which were mostly located in the Northeast and the Pacific Northwest. And in nearly all states, buprenorphine was available or less available in Black and Latinx neighborhoods. So these racial and ethnic inequities were persistent across most states. Next slide. Buprenorphine also ranged substantially across states, availability ranged by state, by counties. And one key takeaway here is that in nearly 1/3 of all counties, there was either no pharmacy located at all, or if they had a pharmacy that did not dispense buprenorphine as of 2023. And the vast majority of those counties, if not all of those counties, were rural. Next slide. And in adjusted regressions, we found that chain pharmacies were just much more likely to dispense buprenorphine than independents. This is really important to think about because independents are more likely to locate in certain areas, including predominantly minoritized communities. We also saw that in these adjusted regressions, buprenorphine was still nearly 4 times less likely to be regularly dispensed in Black and Latinx neighborhoods in comparison to white neighborhoods. And that pharmacies located in urban and low-income neighborhoods were much less likely to offer buprenorphine than those in rural and higher income neighborhoods. So the urban rural inequity that is generally described does not appear in this analysis, and I'm happy to answer questions about that. Finally, next slide. We found that nearly 1 in 5 pharmacies that offered buprenorphine in 2022 had stopped by 2023. So it's not just a question of availability, it's a question of whether you're going to continue making this medication available. And we saw similar inequities, the same story where pharmacies in Black, Latinx, low income, and urban areas were all less likely to stop offering buprenorphine than pharmacies in other areas. Next slide. To sum it all together, given the low rates and inequitable availability of buprenorphine at pharmacies, our findings suggest that patients might be encountering barriers in accessing this medication when they actually go to their physical pharmacies in their neighborhoods. So states should and local governments should consider enacting ordinances that require pharmacies to actually stock a buprenorphine inventory. These type of policies are existing in other medications, including for naloxone, which has really helped increase access to naloxone at pharmacies. We also observed that buprenorphine availability was generally higher in states that have less restrictive prescription drug monitoring programs, and being less restrictive and therefore a little bit more have looser regulations on these opioids might seem counterintuitive, but buprenorphine is a scheduled drug, so these same policies that impact availability of opioids whole cloth also impact or potentially impact buprenorphine access. So it's warranted to at least examine whether less restrictive policies may be warranted. And finally, a failure to ensure buprenorphine availability is equitable and higher overall is going to is necessary to ensure that we actually address this problem and don't exacerbate existing racial and ethnic disparities in OUD treatment. Thank you so much. If you have any questions, feel free to reach out. And now I will pass it on to Maureen Stewart.
Thank you. I'm honored to be here to present findings from our qualitative study of perspectives on pharmacy-based methadone for opioid use disorder. Next slide. I'd like to acknowledge my colleagues at Brandeis University, Boston University, and the University of Rhode Island, and support for this project from the Pew Charitable Trust and NIDA. Next slide. So as we've heard today, methadone, buprenorphine, and naltrexone are the 3 FDA-approved medications for opioid use disorder. Methadone can generally only be dispensed by federally certified opioid treatment programs, which can create access issues. Across the United States, there are about 2,100 opioid treatment programs, and 80% of counties and the entire state of Wyoming do not have one. As a result, in some areas, the average drive time to an opioid treatment program can be up to 2 hours per day. Next slide. So people with opioid use disorder, patient advocacy groups, addiction medicine physicians, professional organizations, scientists, and policymakers have called for expanding access to methadone through pharmacies. This could be possible through at least 2 models. First, under current federal law, pharmacies and OTPs could partner together to operate a pharmacy-based medication unit. In practice, medication units are rare. Secondly, with changes to federal law or regulations, qualified practitioners could prescribe methadone for opioid use disorder, and pharmacies could dispense it just like they do other controlled substances. So the goal of our study was to explore the advantages, disadvantages, barriers, and facilitators to expanding methadone treatment through these pharmacy-based models by soliciting input from a range of perspectives. Next slide. We held 2 community advisory board meetings to interview people with lived experience accessing methadone treatment. And then we conducted individual interviews with pharmacists, many of whom were independent pharmacy owners, OTP leadership, state Medicaid officials, health insurance plan representatives, and state and federal policymakers. Our interviews were recorded, transcribed, and analyzed using a framework method. Next slide. Next slide. Our paper includes detailed input and quotes from all different informant types, but I'll share some examples here. So key advantages identified by all informant types included first, improved geographic access, resulting in time savings for people using methadone now, and also allowing for more people to try methadone. Reduced stigma by treating methadone just like other medications, and increased privacy. Next slide. Potential disadvantages identified by our informants included that comprehensive clinical services are not typically available at pharmacies, that under the medication unit model, geographic access improvements could be limited by proximity to an OTP because of regulatory requirements, and that methadone may be diverted or used improperly, resulting in increased overdose deaths. Next slide. Next slide. Yeah. Barriers to offering pharmacy-based methadone include opaque and restrictive regulations, financial obstacles, stigma, pharmacy staffing difficulties, and resistance to changing methadone delivery. Next slide. Facilitators to offering pharmacy-based methadone included support for changing the methadone delivery system, pharmacist attitudes and trainings, capabilities, clear regulations, and a business case, including financial incentives. Next slide. So people with opioid use disorder want more options for methadone treatment. Pharmacists and independent pharmacy owners expressed interest in participating in a pharmacy dispensed model where methadone for opioid use disorder is treated similarly as other controlled substances. This model could offer a more patient-centered experience. Changes to federal law or regulations would be needed to support either of the pharmacy-based methadone models that we explored. While the medication unit model is currently permissible, our interviewees indicated that clearer regulations could help pharmacies and OTPs understand exactly how to implement the model, and less restrictive regulations would encourage participation. A change to federal law or regulations could allow the pharmacy dispensed model. While OTPs tend to oppose this type of change, they also recognize the need to innovate and provide more flexible, patient-centered access to methadone. Facilitating any new delivery system model requires financial sustainability, and future work on the financial implications of pharmacy-based methadone could inform these legislative changes. Next slide. Thank you so much. And now we'll hear from Lindsay Allen.
Great, thank you so much, Maureen. We are presenting joint work today with Joshua Black and Max Kelly, who is also here at Northwestern with me. So we're going to be talking about the next slide. The changing racial composition of the opioid epidemic, which Dr. Grooms did a great job in the previous panel teeing up for me. I don't have to spend a ton of time here, but the takeaway from this slide is that while we have seen a bending of the curve among white individuals in terms of their opioid overdose rate, we are seeing all of the other racial and ethnic groups increasing. And so next slide, please. One of the reasons we might be seeing this disparity is that there could be disparities in access to naloxone. And so we've been talking about kind of uneven access to different medications, and this is in line with that same theme from this panel. So naloxone is this community administered medication that you are able to carry around as a layperson or as a friend or loved one of someone who's using opioids, and you are able to administer it very easily if someone is having an overdose. Next slide. The challenge with a community administered medication is that members of the community have to actually be prepared and able to use it in the case of an emergency. And so one way to kind of think about how all the different steps that have to take place for somebody to actually engage with naloxone in this way is the naloxone care cascade. So we're not the first to come up with this. We're borrowing this from Tobin et al. But we did adapt it a bit to the survey that we had. We have a really juicy survey that I'll tell you about in just a second, with a lot of information about all of these different steps in this care cascade that have to happen for someone to ultimately use this. And the reason we like this framework is because we can start seeing kind of where along this care cascade we see people drop off. And so we can look at things like awareness. So to use naloxone, you first have to be aware of what it is. And then you next have to be able to access it and then be trained and then actually have it and then carry it, and then finally use it. So there's a lot of places where this could get mucked up a bit. And so we're going to tell you about where those disparities are. Next slide, please. Oh, I think I had some really fun animation here. You can just jazzy it up for us and then hit the next slide. Right. So our approach was very easy to understand. So we used the survey from 2024, the most recent year we have available. And with that, we ended up with about 58,000 individuals who took the survey. And importantly, we're reflecting both the general population and then also high-risk users. So people who have used opioids illicitly in the last year, because that's the group that we really want to be targeting with naloxone. We're going to calculate kind of unadjusted prevalence for each step of the cascade, and then we will throw some covariates into weighted Poisson regression so that we can test for statistical significance. And we'll be displaying the APRs, the adjusted prevalence ratios. Next slide, please. So what you're seeing here is prevalence among the general population across all of the different ways that you can engage with the cascade. And it'll come as absolutely no surprise that white adults had the highest engagement at all 5 of the cascade steps that you're seeing on your screen right now. And then non-white adults have consistently lower engagement. And it's not just that it's lower, it's that it is worryingly lower. So non-Hispanic white is in the teal, and then the other races and ethnicities are in the other colors. Next slide, please. So this is the adjusted prevalence ratio that you're seeing. And so here we're looking at anything under 1 is showing that a certain group is less likely to be aware, be able to access naloxone, for example, compared to white individuals. Next slide. Okay, and then this is among that high-risk group that I spoke of. So adults who have used illicit opioids in the past 12 months, we see very concerningly that awareness is under 50% for all individuals, including non-Hispanic white individuals, and then it just kind of gets worse from there. And so even among this really risky group, we just don't have the awareness or the access or the possession, and then we definitely don't have the readiness for people to actually deploy naloxone. You can see how that gap just persists from white to non-white across all steps. Next slide, please. So in no way am I able to solve this right now, but I do think that we've shown that just making naloxone available over the counter, which it currently is not enough to close these gaps. And we will need more targeted evidence-based strategies to actually get naloxone where it needs to be. Thank you. I'll turn it back to Pooja.
Great. Thank you, everyone, for such wonderful presentations. There's quite a few questions in the chat, and we certainly won't get to all of them. And so I'll try to curate a diverse group of questions here. I think the first question that we'll do is probably going to go back to Dr. Kelly, and a person asked, has there been an effort to provide education focused on the long-term care industry, on the needs, behaviors, and available treatments and stigma issues for skilled nursing facilities?
Absolutely, yeah. Hi, Lowell. Lowell is a collaborator on the paper, an interviewee. We absolutely do highlight educational interventions in the paper. That is really foundational. We have an Appendix 4 supplement that's available, which lists lots of different resources, including the Center for Excellence in Behavioral Health and Nursing Facilities, which is a key resource for facilities seeking that type of information. And then the technical assistance aspect is also very important, and that's coming from different levels, from the level of the state-sponsored efforts with technical assistance, as well as organizations like the Center of Excellence providing technical assistance. Unfortunately, the funding is completing for the COE, but hopefully renewal of similar efforts is ahead. And so, yeah, education is an important part of this, and it's there. The Appendix 4 lists a lot of great resources, so hope you check that out.
Great. The next question for Dr. Guadamus, can you distinguish between pharmacies in your data set that are not willing to dispense buprenorphine versus those that are located in neighborhoods where maybe there's low need or low demand, since it does seem like the data does show that there's pockets of places where there's quite low dispensing?
Yeah, well, we can't distinguish between pharmacies that are just unwilling, except maybe for the group of pharmacies that were previously dispensing and then the following year stopped. So that was a choice, for whatever reason. except for that group, we can't really say if there was a high need and then a pharmacy and a high demand and then a pharmacy decided not to stock it or dispense it for whatever reason. What we could look at was area level measures of overdose deaths. So then there was a population public health need for more MOUD, more buprenorphine access in these communities. And what we saw was that pharmacies located in area, and I didn't present this, pharmacies located in areas with more need did have more pharmacies dispensing, like higher availability rates, but not, so there was a dose, kind of like a dose response finding there, but it's still lower than 50%. So it's better, but it's not ideal. And these are areas with the, in the top quintile, so the areas with the highest rates of overdose deaths at the county level.
Right. And then the next question, I'll kind of bundle a few questions that were sent regarding kind of methadone dispensing in pharmacy clinics. I think a lot of people kind of have mentioned that, it seems like this can be an obvious solution. But then others have questioned kind of the pharmacy's ability to kind of carry out clinical monitoring appropriately. I'm curious if there was any qualitative findings around kind of logistical issues here.
Yes, well, as we mentioned in the presentation, we need legislative changes and regulatory changes for pharmacies to be able to do this, unless they partner with an OTP. We did specifically hear from pharmacies an interest in providing clinical services, and so there is some interest and potentially ability to do that. But under current policies, pharmacists most likely can't bill for the clinical services, so that gets in the way.
Great. And then I think the final question that we've got that I think could apply to all of our panelists with respect to kind of evolving political support for some of the treatments that you all had mentioned, including things around like naloxone dispensing and harm reduction. I'm curious how you kind of see these programs existing as we move forward. I don't know who would like to kick us off first.
I can talk about the emergency department. I think there's been a national effort to change the standard of care that's delivered in emergency departments, and this just being normative practice. It's like what you do. Like someone is in opioid withdrawal, you provide them medications for opioid use disorder to treat their withdrawal. They are at risk for overdose. You provide them naloxone, take home naloxone, and like linkage to community programs, and it really being standard of care in emergency medicine. There's been a lot of initiatives to do that. California Bridge, I think, has been some of the most successful at this, and some of that has been, their model of technical assistance and training support. I worry in this current administration, and this economic climate, that type of support and technical assistance would not be available to try to change practice in other throughout the country. California was able to do this in diverse settings, but and I think does serve as an example of how it could be disseminated in that way in support with community-based organizations. But it requires a fully funded Medicaid in many respects, people to get access to those medications if they're going to continue medications, and the existence of community-based harm reduction organizations to link people to those community resources, need to be available for navigators to connect people to.
I can jump in and tag on that. Thanks, Liz. I think when we're talking about evolving support, I think we can imagine waning federal dollars. And I think that this is a really good place for some of that opioid settlement money to be used. I think when the settlement money was first coming down, we didn't know where to start. And I think an eye toward these evidence-based practices and treatments is a really good place to start when we are thinking about how to allocate that money most effectively, most cost effectively. I think really helping people understand the cost. I am a health economist by training, so I'm always going back to the cost, but helping people understand the costs associated with the opioid use disorder kind of burden is really important. And then I think we're seeing some really innovative work being done at the state level. So much of this is up to the states. And so I know a lot of states are implementing naloxone vending machines, for example, and those are lower cost. They collect terrific data that we can use to study their effectiveness moving forward. And it really brings the medication to people in a non-stigmatized way.
Could I add something really quick? So, and we have none of these papers, including my own, didn't really touch on this. But with the federal environment changing and the Medicaid cuts looming, all of this is going to change. I can see a world where the reimbursement rates for buprenorphine are already pretty low, including for Medicaid, which is a huge population in need. So the number of, or at least in my area, of pharmacies dispensing buprenorphine and choosing to for Medicaid patients, I imagine is going to shrink. So placing all of this in the federal context will be critically important.
Great. And that it's our time is up, and I wanted to move on to introducing our next panel, which will be led by Dr. Brendan Saloner, who will be talking about opioid treatment coverage, access, and quality across payers. Dr. Saloner is the Donald G. Miller Professor of Alcohol and Addiction Studies in the Department of Health Services, Policy, and Practice at Brown University. Dr. Saloner?
Thanks, Pooja. So I'm back, and I'm back with 5 friends, and I'm going to introduce them now, and then we're going to go briskly through their presentations and hopefully save some time for comments. So Tammy Mark is the Distinguished Fellow of Behavioral Health Financing and Quality Measurement at RTI International. She'll be followed by Tamara Beetham, who's a postdoctoral research associate right here at Brown University, followed by Karen Shen, an assistant professor of health policy and management at Johns Hopkins University. Next will be Stephen Crystal, who is the director of the Center for Health Services Research and distinguished professor at Rutgers University. And finally, Michael Barnett, a professor of health services policy and practice, wouldn't you know it, at Brown University. So we will go right to Tammy. Tammy.
Great. Thanks, Brendan. Wonderful to be here. And thank you for the opportunity. So in our study is a collaboration between myself and my colleagues at RTI, William Parrish, Miku Fujitsu, and Mingyu Sun, as well as Deborah Steinberg at the Legal Action Center. It was funded by the Legal Action Center. And in our study, we used Medicare enrollment claims and encounter data from all Medicare beneficiaries in the US in 2020 to examine the extent to which Medicare beneficiaries with opioid use disorder receive treatment in accordance with 8 nationally recognized quality measures. Although CMS regularly assesses the quality of opioid use disorder treatment for Medicaid beneficiaries, to our knowledge, they are not comprehensively assessing the quality of opioid use disorder treatment for Medicare beneficiaries. And that's despite the fact that we know that approximately 1.9 million Medicare beneficiaries have an opioid use disorder. So just to get right to the chase, this slide shows you the results for the 8 metrics that we assessed. These are quality measures that are used in national systems such as CMS's Medicaid Adult Core Set, the CMS Merit-Based Payment System, and NCQA's HEDIS measure system. The first 2 measures on the slide you can see are initiation and engagement. And we can see in red that only 29% of individuals with a new OUD diagnosis received treatment within 14 days of their diagnosis. That's the initiation measure. If we move on to the engagement measure, only 11% of beneficiaries with a new OUD diagnosis received 2 or more OUD services or medications within 34 days of the initiation visit. So very low initiation and engagement rates for this population. The next measure is the percentage of beneficiaries with an OUD diagnosis who received an MOUD, as we've heard previously. MOUDs are extremely effective. Methadone, buprenorphine have been shown to be able to reduce the overdose death rate by half. And we see that only 16% of Medicare beneficiaries with OUD in 2020 received a medication. Looking at the next measure, continuity on pharmacotherapy for OUD, and that's looking at the percentage of Medicare beneficiaries who stayed on an OUD medication for at least 6 months, because we know that effectiveness depends on staying on it for an adequate amount of time, 6 months being the minimal amount thought to be effective, and there the rate is only 19%. The next 4 measures look at whether patients who had an OUD-related acute care event that required a ED visit or hospitalization received follow-up after those events, and we see that only 14% and 20% respectively received follow-up after an ED visit, and then in terms of hospitalization follow-up, only 31% and 38% received follow-up within 7 and 30 days respectively after an OUD hospitalization. So if we look across all these measures, less than 40% of Medicare beneficiaries were receiving OUD that met the quality standards. If you look at the results comparing the yellow and the blue lines, those are comparisons between Medicare fee-for-service and Medicare Advantage. And across almost all the measures, Medicare fee-for-service performed better than Medicare Advantage across 6 of the 8 measures. Finally, for 3 of the measures, we were able to compare Medicare to Medicaid. Those are shown in green. And you can see that the Medicaid performance is much better than the Medicare performance. So we think that the take home here is that we need to be monitoring Medicare quality metrics for the OUD population, similar to what we're doing for Medicaid, and that can help us inform whether our policies to improve access and outcomes for Medicare beneficiaries with OUD are succeeding. Thank you. And I think I'll pass it on to Tamara Beetham now.
Thank you. So this is work with Helen Newton from UNC, Chima Nutamale, David Feline, and Susan Bush from Yale. And we're considering a Medicaid policy that was intended to increase access to medications for opioid use disorder, and having a look at how that played out. Next slide, please. So the motivation here is that oftentimes evidence-based services, and particularly medications for opioid use disorder, are often not provided despite the evidence of the protection of overdose. And this is the case for residential treatment in particular, where in the most recent data, only 1 in 10 residential treatment patients had medications for opioid use disorder in their treatment plans. Next slide, please. And the policy we're looking at here is the Medicaid Section 1115 IMD Substance Use Disorder Waiver, which is a policy that was intended to improve access to medications for opioid use disorder in residential treatment. So it started in 2015, where states could obtain this policy. They would, but in exchange, they would need to cover residential addiction treatment and medications for opioid use disorder in their state Medicaid plans. And crucially, Medicaid participating facilities must also make medications for opioid use disorder available. Next slide, please. So here we consider the question of whether this waiver is associated with access to medication for opioid use disorder in residential facilities for Medicaid beneficiaries. And we're also interested in understanding the mechanism through which change might be occurring, and whether it's these existing facilities that were here throughout the duration of this study changing their own behavior, which is of particular interest because sometimes providers may have philosophical beliefs or views that are sort of inconsistent with using medications for opioid use disorder, or through facility entry and exit, which there's a lot of openings and closures within residential addiction treatment. And so we consider what role that might also have in the policy effects. Next slide, please. And so we use national survey data from 2012 to 2022, and we compare facilities in states with the policy compared to facilities in states without the policy. And the outcome of interest here is whether facilities report that they accept Medicaid patients and that they also provide medications for opioid use disorder. And then we also decompose the sort of underlying mechanism in these changes. Next slide. And so essentially we find that facilities in these waiver policy states are much more likely to accept Medicaid and provide medications for opioid use disorder after the policy. In the teal line here, we see there's a baseline of only 18% of facilities that are both offering medication and accepting Medicaid patients. And then at least 4 years after the policy, there's a 144% increase. That's up 26 percentage points. And then when we look at the purple line, this is looking at facilities compared to themselves the prior year, and we see the effect is much more mitigated. And so next we look to sort of unpack what might be going on underneath. Next slide, please. And essentially we see that when separating effects in the number of facilities per 10 million that both offer medication and Medicaid, that close to 90% of the increase due to the policy is coming from these facilities that are opening and closing during the study period. And only about 10% are coming from continuously operating facilities. And in a further decomposition, we see that facilities that start out without Medicaid are more likely to start accepting Medicaid patients compared to the control group. However, the facilities that start out without medication are not more likely to start offering medication compared to the control group. Next slide, please. And so so essentially we conclude here that the waiver policy does seem to be associated with an increase in access to medications for opioid use disorder for Medicaid beneficiaries, but that much of this increase is actually coming through this facility openings and closures, particularly openings, and that these rather than from the continuously operating facilities, which particularly when it came to medication, didn't actually improve relative to the control group. And so the implications here is in sort of broadening our scope of thinking about how policies have the potential to work, and that reshaping the provider market might be something that that could be operating underlying these policy effects. And so that's something that future policy design and policymaker design and policy evaluation should consider. And it's particularly of interest because these waivers are only for 5 years. And so there are several different proposals for permanent options. And so that's you know, something that's particularly policy relevant at the moment about how we're sort of going to manage that going forward. And that's it. Next slide, please. And thank you. Feel free to reach out with Tamara_Beetham@brown.edu. Any questions? And we'll pass it off to Karen Shen. Thank you.
Great. Thank you so much for having me. My name is Karen Shen, and today I'm presenting joint work with Ben Thornburg, Aline Kennedy-Hendricks, and Mark Meiselbach. Next slide, please. So our project, similar to many in this panel, was interested in the role of insurance in shaping access to treatment for people with opioid use disorder. And in particular, we were inspired by evidence from the National Survey on Drug Use and Health that suggests that people with Medicaid insurance are significantly more likely to receive medication than people with commercial insurance. There are a number of potential explanations for this raw difference that we could come up with. For example, this could be due to the different patient composition of patients in Medicaid versus patients in commercial insurance. Medicaid enrollees are disproportionately located in certain parts of the country, and they have different demographics than commercial enrollees. It could also be explained by the fact that Medicaid enrollees tend to receive care in different settings and from different providers than people with commercial insurance, and those providers may be particularly attuned to the needs of people with opioid use disorder. And finally, it could be due to the direct impacts of insurance on access. For example, we know that Medicaid has very little cost sharing and robust coverage of methadone treatment. So our research goal was to dig into this a little bit more and disentangle these potential factors. Next slide, please. So in order to do this, we took advantage of an all-payer claims database from the state of Wisconsin for the years 2021 and 2022. This database contains 100% of Medicaid enrollees and roughly 40% of commercial enrollee claims from the entire state of Wisconsin. And we identified a study sample of people with opioid use disorder. And we also used the entirety of each patient's claims to assign each patient to a primary care provider where possible. And our main outcome variable was whether or not a patient in our study sample received MOUD in a given quarter. Next slide, please. So first, we describe differences in both patient and PCP characteristics by insurance type. And some of our findings are highlighted in the table and to the right of the table. So we found that Medicaid enrollees are younger, more likely to be female, and more likely to have serious mental illness and co-occurring substance use disorders. And we also found that their PCPs were also similarly more likely to be younger, more likely to be nurse practitioners or physician assistants. And when we looked at the share of each PCP's patient panel that had OUD, we indeed found that Medicaid enrollees were more likely to be seeing PCPs who in turn saw a greater share of their patient panel with opioid use disorder, so potentially had more experience with OUD. Next slide, please. When we looked at receipt of MOUD across insurance types, we kind of confirmed the national survey data finding that Medicaid enrollees were more likely to receive MOUD than their commercial insurance counterparts. So we found that in Wisconsin, 61% of Medicaid enrollees with opioid use disorder received MOUD in a given quarter, compared to 51% of commercial enrollees, corresponding to a gap of approximately 10 percentage points. On the right, you can also see that most of this difference is driven by significantly greater methadone use among Medicaid enrollees than commercial enrollees. Next slide, please. So the paper does a number of adjusted analyses to look at how that unadjusted gap of 10 percentage points changes as we add the different patient and PCP characteristics that we were able to measure. The main finding is that even in the most saturated models where we include both patient and PCP characteristics, we are able to explain at most 30% of the gap between Medicaid and commercial insurance. So a significant gap remains. Next slide, please. So our takeaways from this significant remaining gap is that there is potentially a role for direct insurance effects in explaining the difference between Medicaid and commercial insurance. So it may indeed be that policies like cost sharing and coverage of methadone might explain higher rates of treatment among Medicaid enrollees compared to commercial enrollees. Some of the characteristics that we dig into the paper that do significantly explain treatment rates were patient age and provider experience. And we think that these motivate a greater focus on older populations and continued efforts to train more providers in being comfortable prescribing or referring people to MOUD treatment. There's a host of limitations and sensitivity analyses that I won't get into today, but I encourage you to read more in the issue. Thanks so much, and I'll pass it to Steve.
Okay. Your timing was perfect. I hope I can be as good. So what we want to talk about using relatively recent national data that cover all payers, including self-pay, is this big question of why we failed in the whole period, pretty much since the 2017 first national declaration of a public health emergency, to have the improvements that we were hoping for in MOUD and particularly buprenorphine uptake, and to get some sense about the policy drivers, the role of state state. So those of you who remember the fight over eliminating the X waiver and many of the other fights about maintaining pandemic era flexibilities, there's really been enormous changes in national policy since 2018. Advanced practice providers becoming much more substantial, many fewer barriers, and becoming a much more substantial part of the provider force, thus theoretically reducing supply barriers, elimination of the X waiver, telehealth. But yet we see in national data, all payer in particular, relatively little net progress on this. And thank you for anticipating. This is the story that I mentioned. Next slide. We start this period with tremendous 2018 to 2024 with tremendous disparity across states, and end up with tremendous disparity across states, 38-1 in terms of all payer buprenorphine per population. But with rotation among states, so that the relatively flat trend conceals enormous variation. Here you see that in this time period, 13 states of relatively flat national use, 13 states actually improved more than 50%, 13 states declined, and the Medicaid expansion status, particularly the late expanders, was very strongly associated with the progress of groups of states, with the late expanders improving by 27%, the non-expanders actually declining, and increasing disparity by expansion status. So you see that in this time period in the red, this southeastern area with several important expansion states actually declined, while you had substantial improvers in some of the middle of the country with the late expanders. Next slide. You see that in terms of Medicaid prescribing, also remained enormously disparate, but you had some real success stories. You have virtually no Medicaid prescribing in states like Texas, and 217 per thousand in West Virginia. Significant declines in 11 states that are discussed in a separate paper in JAMA Health Forum led by Sumedha Gupta. Medicaid changes, key drivers of all payer change. Next slide. Here you see that the gap between looking at the top at the all payer rates, the non-expansion states remaining flat, while the recent expansion states improved to converge with the early expansion. Next slide. The paper contains a lot of information about the burden of self-payment, which ranged from 0.7% to 31% that in Mississippi. Next slide. And we see that these expansions that were important success stories are already at risk. And there are already some legislative changes taking place in some of these states as a result of the new OBA financial pressures. Next slide. So big picture question here. Policy innovations that we thought would be more definitive, like eliminating the X waiver, had less impact than we hoped, but enormously moderated by state factors. So we're going to see in the coming era even more dependence on state action, and potential for the differential implementation of OBA to lead to worsening of existing severe cross-state disparities. Next slide. We have to remind ourselves that the OUD population is very much concentrated in the expansion population. 61% of all people with OUD and Medicaid are eligible virtue of expansion. What we're going to need to be looking at in the coming years is looking very closely at the potential effect of these policy changes, these Medicaid policy changes on retrogression, which we've already seen during unwinding in some states, and the potential for it to be worse. So very much centering, final slide, very much centering state policy as a place that we're going to need to be looking to try to even maintain the progress that we've made. So thank you.
All right. Thanks, everybody. It's great to see such a huge audience here. My name is Michael Barnett. I'm a professor at Brown University School of Public Health, and also want to acknowledge my co-authors, Ellen Latsko and Alina Denham at Stony Brook University. And we're going to be talking today about Medicaid and methadone expansion of coverage in Medicaid. Next slide. So the background here today, I won't go through the whole process of describing why MOUD is important. I think we've established that. But what's, I think, somewhat shocking for us to have learned and inspired this study is that prior to 2018, there are actually 11 state Medicaid programs that didn't cover methadone at all for OUD treatment, which, as we've heard in other talks, Medicaid is a very big player in the OUD population in the US. So this is a significant gap. Luckily, policymakers were not unaware of this, and the Support Act passed in 2018 mandated that actually state Medicaid programs cover all FDA-approved MOUD, which meant that these 11 states were mandated to start covering methadone in October of 2020. So in this paper, we fill an evidence gap, which is that very little evidence to this point has actually addressed what the effect of the Support Act was. Next slide, please. So our study questions were, first of all, what was the impact of support-mandated expansion of methadone coverage on both overall methadone distribution in opioid treatment programs, or OTPs, as well as OTP acceptance of Medicaid insurance, and also looking at the relationship between this expansion and methadone and overall opioid-involved overdose rates. Next slide. So we had 3 data sources. I think a primary strength of our study is we actually combined data sources with many different overlapping sources of evidence on the same question. To look at methadone distribution, we look at what's called ARCOS summary reports that are made by the DEA, which summarizes controlled substance distribution to individual facilities and states. We used quarter-level data on methadone distribution to states, which we had to infer the amount that went to OTPs by looking at annual level data on how much methadone was distributed at the state level. We used well-known CDC mortality data to look at overdose mortality rates. And then we also used mental health substance use facility survey data from SAMHSA, which is captured annually to look at OTP insurance acceptance. Next slide. So we confirmed methadone coverage start dates for 10 of the treatment states. One of them, Wyoming, has no OTPs. And after confirming those coverage start dates by either public search or talking with state authorities, we basically sorted every state into event time, similar to other papers that have been discussed in this session, and looked at treatment states compared to control states that did and didn't have support mandated expansion. We matched our control group based on pre-period trends in opioid overdose mortality and also OTP methadone dispensing. So every treatment state was matched to a control state. And we used different differences models at the state quarter level, controlling for the information we had available, which is state, quarter, and event time. Next. So this figure here shows our sample divided into control and treatment groups in yellow and red, as well as the national trends. And it shows each of our treatment states highlighted. And this isn't an event time. This is just the amount of methadone dispensed per 100,000 population over the whole course of all of these states expanding. What you can see here in these unadjusted trends is that actually the gap between the control and treatment groups narrows over time as each of the states expands, and also that the treatment groups are starting off with substantially lower methadone distribution than the control group at the beginning. Next, please. After we use our regression models, this is the adjusted event study. And in red, you can see the treatment group, and in yellow, you can see the control group. So after adjustment, basically in the control group, methadone distribution changed very little over this time period. Whereas if you look at the treatment states, we actually see a gradual increase. And this translates into a 13% increase in methadone distribution in the treatment states relative to the control states. In annual survey data from SAMHSA, we also found a statistically significant increase in the percentage of OTPs accepting Medicaid. Next slide. It is important for us to also look at potential countervailing trends. So in yellow here, one important question is if methadone availability increased, did methadone overdose rates also increase? What you can see here is the treatment groups are in solid and the control group is dashed line. In yellow, we have methadone overdose rates, and there is actually not a significant increase in the treatment group in methadone overdoses. You can see that on the y-axis, methadone overdose rates are only a tiny fraction of overall opioid overdose rates on the left-hand side. That's in blue. Here, what we see is actually there is a post-expansion uptick in opioid overdose deaths that we see specifically in the treatment group. Next slide. So to wrap up, what we found is that Support Act mandated expansion of coverage was associated with significant increases in methadone distribution, and there was no corresponding increase in methadone overdoses. Our conclusion from this is that actually out-of-pocket costs for methadone are probably a non-trivial barrier for many Medicaid enrollees because the only option for them to access methadone without this expansion would have been to be cash pay. And we don't want to have it both ways, that we're going to say there was no increase in methadone overdoses, but the increase in opioid overdoses was not due to expansion. But we actually think the increase in the treatment group we see in opioid overdoses reflects concurrent patterns in COVID-19 and a less robust infrastructure in the treatment states at baseline. And it emphasizes that methadone alone is not the solution to the opioid crisis, but we have a continued need for other comprehensive solutions. Next slide. Thank you, everybody.
All right, great. I'm going to now facilitate some questions with the panelists, and I want to just tell you all how energized I was to read these papers. They're really all terrific. Please read them. So I'm going to try to ask some rapid fire questions that I want all of you to answer. We'll see if this works. The first question that I want you all to reflect on is, well, here's the premise. So Medicaid often is sort of criticized for being inferior to other insurance types, private insurance or Medicare. But actually, I think one of the interesting things we can see looking across these papers is just how impactful Medicaid has been and how it often outperforms other payers. And I want you guys to just reflect on the tools that Medicaid programs have at their disposal to influence outcomes for their beneficiaries. And I would like you each to reflect briefly on the question of what do you think Medicaid has been doing right in the last few years? Just think of one thing, and what is one thing that you think Medicaid programs could be doing better? Like if you were talking to a Medicaid state official, what advice would you give them? So we'll just go in the order of presentations. So I think that would mean we start with Dr. Mark.
So relative to Medicare, which was the focus of my our research, Medicaid is a much more robust benefit. It's Medicare didn't cover methadone until 2020. For example, Medicare only started covering intensive outpatient services in 2024, and Medicare still doesn't cover residential for OUD treatment. And the MAPIA, the Mental Health Parity Act, doesn't apply to Medicare. So I would say that in terms of improving Medicare access, we need to continue to expand the robustness of the benefit. What both of them could do probably is re-examine their use of prior authorization. We know from just gobs of research that prior authorization is a barrier to accessing medications, and it's not really used. It doesn't improve quality at all. So I think that's an area where both Medicaid and Medicare could improve.
Great. Dr. Beetham.
So I think both of these could be things where there has been some improvement, and there are also things that could continue to be improved. The coverage of residential in particular, as a waiver, it's still something that is only state opt-in. And so coverage of these services, particularly within residential treatment, and requirements that there are evidence-based services is something that it's still lagging behind. There have been some improvements there with the waivers. There's been more coverage, particularly for outpatient as well, in sort of covering medications for opioid use disorder, which previously were denied. So there's efforts being made to move forward, but still work to do, I would say.
Okay, next is Dr. Shen.
So I think Medicaid has done a really good job of, especially for low-cost treatment like buprenorphine, reducing as many barriers as possible to access to that treatment. And also making pretty good use of care coordinators in general compared to other payers, I think. I think that something Medicaid still needs to reckon with is access to kind of higher cost treatment, specialty care, wraparound care, mental health care. So I think all of those things go along with medication and might be missed.
Thank you. Dr. Crystal.
So many things to think about, and Tammy has contributed to several of them. Generally on Medicare, I would certainly acknowledge the historical limitations, but drawing from various kinds of work, including ours and also some of Tammy's, Medicare, I think, has actually been a little more consistent with removing prior authorizations, and that's one thing that Medicare has done right, and not all the
Steve, Medicaid or Medicare?
Medicare has done right.
Okay.
And still not all Medicaid plans are there in terms of how they're using their utilization management. And one also has to look at the interaction between these two programs, because it really makes a difference whether you're a dual or whether you're one or the other only. That's a messy area. We still don't know whether special need plans actually improve the care for people or just methods of trying to have cost containment. In terms of things that Medicaid programs have done right, as Tammy alluded to, Medicaid, by virtue of its history in more robustly covering services that aren't strictly medical, has been able to deploy navigator programs, care management programs of all sorts, peer navigator programs in settings like correctional, in settings like EDs. So Medicaid has really stepped up in some states like New Jersey with the navigator, the ED navigator programs. So Medicaid has the potential tools to do more. The waiver structures allow it to do more. But all of those things I think are under threat. And I think we're going to, if we have this conversation again in 2 or 3 years, we may not be so sanguine about Medicaid versus Medicare. The final thing I would say is we really need to look at all the major payers, because in many ways, the real lagging policy changes have been in commercial. And there's still a lot of utilization barriers in commercial that was touched on by the paper that showed less access when you control for appropriate things for commercial. And I think we really need to start looking at those remaining barriers in commercial. So it's a very complex landscape.
Dr. Barnett.
Right, it's a tough group to be last in a round robin, but I'll take maybe a step back a little bit in terms of what Medicaid is doing right, and just point out something that Steve had in his talk, which is just how important the expansion population is for OUD, and that I mean, having Medicaid coverage and being in an expansion state is, I think, potentially one of the most powerful policy interventions that we can have to help people with OUD. And also coming back to the idea of like commercial plans lagging, like that's not an accident. They don't want patients with OUD on their plans, right? Like Medicaid really in some ways is our national program that has a mandate to provide this treatment because they're the ones treating this population disproportionately. In terms of something that they can do better, one thing that I find particularly alarming the more and more I learn about methadone treatment, and this was highlighted in Travis's talk, is just how inconsistent methadone and OTP regulation is across Medicaid programs and across states. there's really no clinical justification, and the amount of hoops that patients have to jump through, and honestly, some of the cruelty that is really that people are subjected to when it can be completely different across the border is, I think, almost a human rights issue that states can come together, or we can have some kind of global standards to make that more consistent.
All right, great. I'm going to now completely switch gears, and I want to now look at your 5 papers through the lens of research methodology, because I think these papers all, in really interesting ways, push our field forward in terms of substance use services research. So the question I have is, if you were teaching your paper to students, what is like the one methods innovation that you would highlight, and what are some of the ways that we could push the field forward? And we only have a couple minutes for this, so I want to start with Dr. Mark.
Yeah, I mean, I'm a data nerd. I love data. And what was exciting about this paper is we had access to Medicare Advantage data for the first time. So I would just encourage students to look for new and interesting paper. We know 50% of Medicare beneficiaries are in Medicare Advantage, and it wasn't available to analyze. And then we actually didn't do, in the paper, we did some adjustments looking at, whether the quality measures differed by subpopulations like duals or not. But I think being thoughtful about how you adjust for things is important, because these measures are supposed to be, they're process measures. So everyone is supposed to, with OUD, is supposed to get an MOUD. It's not supposed to be adjusted for. So I think not over adjusting would be something I would, or being thoughtful about your adjustments and how you use them and what the conclusions are when you use them and how they might change would be something I'd encourage students to think about.
So wise. Dr. Beetham.
So we actually used transition probability matrices in the evaluation, in addition to sort of more traditional policy evaluation methods. And essentially, this allowed us to really sort of disaggregate what was occurring in a policy where there were kind of multiple things happening, and being able to help understand what is going on underneath the hood when you see increases is helpful for improving future policy making and evaluation, and additionally sort of the inclusion of openings and closures of facilities can also help to facilitate or undermine policy effects, and that's something else that can be taken into consideration.
Great. I'm looking for 1 or 2 sentences. Dr. Shen.
So we wanted to use data that could compare Medicaid and commercial enrollees. So we wanted an all-payer claims database. And when we looked at all of the all-payer claims databases that actually had both Medicaid and commercial and didn't censor substance use claims, we were basically down to Wisconsin. So this is just a plug for states to improve their APCDs so that we can study these important questions.
Excellent. Dr. Crystal.
Make sure that you try to have a design that uses all the available data to look at the forest, even as you're looking at the trees, and try to understand the dynamics of the system as it relates to all the different payers. For example, the relationship of Medicaid prescribing and expansion to all payer prescribing. And we've seen actually that some of the earlier studies, we find different results of the impact of expansion, and expansion in the later period is not the same thing as the impact of expansion in the earlier period. And we found some actually very robust effects of expansion in the later period. So the point about a policy innovation with a given name is not the same in its initial implementation as it is later on, or is it when deployed in a different time period. Finally, trying to get to the data that are newer, and understand the use kind of data like that to look at state variations to understand policy drivers of all these variations.
Okay. Michael, you got the last word, and it's 1 or 2 sentences.
Yes, I'll be brief. So There's a lot there's a lot under the hood for, I think, all of our papers. I'd say for my paper, especially when you're doing analyses at the state level, you don't have that many units. You really need to like look at all of the data and actually look at, you can't just fit a model and then just see the results that pop out and say, oh yeah, that's my effect. You need to actually look at the unadjusted trends in your data and everything that's happening, because it can often challenge a lot of assumptions you may have made.
Great. I want to thank all of you for your great presentations, and I'm now going to pivot to the next panel on treatment gaps for youth and justice-involved individuals, moderated by Dr. Noah Krofshek, who is an assistant professor in the Department of Population Health at the NYU Grossman School of Medicine and associate director of the Center for Opioid Epidemiology and Policy. Noah.
Thanks, Brendan. It's great to be here, and I've already learned so much from all the other sessions, and excited to talk and introduce our panelists for treatment gaps for youth and justice-involved individuals. To go in order of the panelists, before turning to them, we will first hear from Sarah Bagley, who's an associate professor of medicine and pediatrics at Boston University. We'll then hear from Eric Weintraub, who's an associate director at the Keller Institute for Addiction Medicine at the University of Maryland. Then we'll have Elizabeth Van Nostrand, who's an associate professor of health services administration and policy at Temple University. We'll then hear from Megan Perry, who's the founder of the Megan Perry Group. And last but not least, we'll hear from Andrew Goodman, who's a board member for the National Coalition to Liberate Methadone. So without further ado, I will pass it over to Sarah.
Was I muted? Could you hear me? No.
Yeah, now we can hear you.
Now you can hear me. Ooh, and now. Sorry. Hey, everyone. I'm Sarah. I'm here to present on behalf of co-authors our paper, Fewer Than 1 in 3 Adolescents with Past Year Opioid Use Disorder Received Substance Use Treatment 2022 to 2023. I have a lot of slides. It's sort of rapid fire results, but hoping that will get you excited to read our paper and ask some questions in the panel. The objective was to examine the most recent available data on adolescent opioid use related treatment. And this is because of, there have been recent policy changes that many of you may be familiar with related to telehealth or prescribing medication for opioid use disorder in the setting of increasing adolescent opioid related deaths. And so our research questions were, what percentage of adolescents with opioid use disorder receive any substance use treatment? What types, settings, and referral sources are most common? And how many opioid use disorder treatment facilities with adolescent tailored programs are available nationwide and in different states? We used 3 national data sources to answer these questions. I'm just going to review each of them. The first was the National Survey on Drug Use in Health, which is an annual survey representing the U.S. civilian non-institutionalized population that is 12 and older. The treatment episode data set, admissions data set, which records admissions to state licensed or certified substance use treatment programs that receive federal funding. So that part is important. And then the National Substance Use and Mental Health Services Survey, which is an annual survey of substance use and mental health treatment facilities in the U.S. And approximately, 85% of these eligible facilities participate in the survey. And importantly, these are also programs that do not receive federal funding. So what did we find? So we found, about 31% of adolescents, so defined as people ages 12 to 17 who met a criteria for opioid use disorder in the past year, reported receiving any kind of substance use treatment. The most common settings of substance use treatment reported by adolescents were outpatient settings other than a school or medical office, school or health counseling centers, and emergency departments and hospitals. However, we also found that 7.1% or 7.7% of adolescents with an opioid use disorder reported receiving medications for opioid use disorder, compared to 19.3% of adults. So one of the first take-home points that's important. When we looked then at sort of the admission sort of referrals and where those were coming, we learned that 28.7% of opioid related treatment admissions in adolescents were self, family, or friend referred, compared to 58% in adults. And interestingly, 27.8% of opioid-related treatment admissions for adolescents were referrals from the criminal or legal system compared to 17% in adults. The 9.5% of opioid-related treatment admissions in adolescents included medications for opioid use disorder in the treatment plan compared to 36.4% in adults. And 23.3% of facilities treating opioid use disorder reported offering an adolescent tailored group or program compared to 8.8% for resident. And the percentage, if you just looked at residential programs, it was only 8.8% of residential programs. Finally, I mentioned we were interested in sort of looking at geography and sort of whether or not there was state variation. So for every 1,000 adolescents who had past year opioid misuse, we asked this question, how many facilities are there that treat opioid use disorder and offer a tailored program or group for adolescents? And what you can see here is that Washington, D.C. and 11 states, most of the states are in the southern part of the United States, had fewer than 5 treatment facilities with tailored adolescent programs for every 1,000 adolescents with past year opioid misuse in this population. And I think this sort of tells an important picture as we're going to sort of talk about implications and sort of what we need to be thinking about next and where we should be ensuring and to ensure that adolescents have access to evidence-based care that they deserve. And so, in sort of thinking through, again, sort of like rapid fire results, like how does this fit into sort of what we already know about adolescent access and to treatment and what we sort of need to be thinking about going forward? It's really consistent with past work that was done, but finding that in general, adolescents have lower access to any kind of treatment. They have lower proportions of adolescents with opioid use disorder receive treatment with medications. Really, we're talking about buprenorphine. And so that has been consistent even sort of into 2022, 2023. And, as someone who sort of conducts research about this, but also take care of the patients, both adolescents and adults, really think about how we can't assume that sort of strategies to improve access to both treatment for opioid use disorder and overdose prevention and harm reduction. If we focus only on adults, we can't assume it's going to trickle down to adolescents, and really need to think about, as we are thinking about improving access, to ensure that we have like youth specific sort of responsive plans. And I think we can be really proud of a lot of work that has been done to in primary prevention, and we've been seeing decreases in the prevalence of substance use among youth, but there is still this group of youth with opioid use disorder who are sort of really high risk and are really continuing to not be able to access the evidence-based care that they need. And so sort of, I think it's like a call to action to not be forgetting adolescents as we have these conversations about access to opioid use disorder treatment and overdose prevention, including methadone, which I'd be excited to talk about at the end as well. But thanks for having me.
Thank you. Appreciate being invited to speak about our paper. Our paper really talks about our experience in implementing a telemedicine buprenorphine program in rural jails in Maryland. You can go to the next slide. I want to thank all my co-authors and for helping us out. We've talked about how important MOUD is in saving lives and trying to expand access. And we've also spoken about rural areas and the need for expanding access in those in rural populations. So for incarcerated individuals have really high risks of high rates of SUD and OUD. Approximately 15% of jailed individuals have OUD. It's probably higher. And the period, if you can look at the graph, the 1 week following release from jail, the rates of overdose deaths are extremely high, as patients that are not treated with MOUD have no tolerance. And with the toxic drug supply that we've talked about, they're really at high risk for using and overdosing. Next slide, please. In 2019, actually, thanks to a grant from the Ford Foundation, we wanted to expand. We were already working in rural areas and just found out that a lot of our patients that actually had been doing quite well in treatment would get incarcerated, wouldn't be able to follow up with treatment. So Ford actually gave us a grant, and over the last 6 or 7 years, we've been battling to implement and develop programs in rural jails to provide buprenorphine. And actually, we've been able to actually do methadone as well, but we can maybe talk about that later. At the time of the when we wrote this paper, we had treated about 750 patients. It's now well over 1,000. And we're in 7 different jails, as you can see, mostly on the Eastern Shore of Maryland and in Western Maryland. Next slide, please. And there's some of our current numbers. We go to the next slide. Some of the implementation challenges. So initially I went in kind of, talking about science, we got to do this, we got to save patients, but quickly learned that needed to work with the detention center teams who were not there to necessarily provide treatment, but to enforce to provide enforcement. So it's really been a collaboration, and we've learned our team a lot over time how to work with detention centers and get county buy-in. There's a lot of stigma towards MOUD in jails. A lot of the people that work in jails will say we've been trying to keep these medicines out of our jails because they're misused a lot. There's a lack of medical unit space in many jails to provide treatment, because a lot of the jails we work in are like 75 to 100 individuals. There's a lack of staffing, both nursing, peer recovery specialists, social workers, and counselors, and even correctional officers. And to medicate people every day, it takes a lot of personnel. There's also concerns about diversion, and having a reliable funding stream is also a challenge to provide support for the programs. Next slide, please. Did we talk about okay. One thing, I don't know if we skipped the slide, but in 2023, Maryland, so there was a policy issue. Maryland passed a law that mandated that all 3 medications that are FDA approved for MOUD be provided in the different jails. Yeah, I didn't talk about that. Thank you. Which actually helped spur our program forward, because all the counties were required to do this by law. The 2 problems with the law are there was no mandated funding with this, no funding stream attached to it, and there's really no teeth to it either. There's no penalties or anything if you don't do it, but still many of the jails were encouraged to push forward once the law was passed. You can jump ahead to the next couple slides. Yeah, so key lessons learned. There's a saying that you've seen one jail, and we found that to be very true. We had to work with a triad of health departments, nursing, and medical teams, and then also the correctional teams. And the triangle is always different. Sometimes the correctional teams are very supportive, sometimes they're not. Sometimes the nursing staffs are supportive, and sometimes they're not. And sometimes we get a lot of support from the health departments. We've learned that early engagement with jail staff is really critical, providing team-based care, working with the nurses, encouraging them to be champions for the telebuprenorphine program. If you can find one nurse that really champions this, it's very helpful. And then the other thing we learned is just you have to really proactively plan and do discharge coordination from day one, because you never know when somebody's going to leave the jail. Could be a Friday night when they go to a bail hearing. So really getting on top of that was really critical. Next slide. So just our summary of what we try to describe is telebuprenorphine works. It's actually a really nice way to get into the rural areas where there are lack of providers. We had a really high rates of retention, continuity, and we have some data that we're going to be publishing that shows that it really decreased overdoses. There's certain things you want to do with every jail. We have SOPs, but you must adapt per jail. And the things that we learned were we had to build trust, do joint training, have flexible models for the local context, and really ensure linkage for post-release treatment. And I think the last slide is just some acknowledgements. Oh no, this was, we did some qualitative work, and here's like a perspective from one of our jail program nurse administrators, and basically just, again, echoing that the key to success is teamwork and a strong relationship between custody and medical professionals, and being flexible about a variety of different how your intervention is implemented. And the last slide, I think, is our acknowledgement. I want to thank the Four Foundation and actually all the wardens, medical staff, and county health departments that really help us put this program together. Thank you. And then I'll turn it over to Elizabeth to talk about what she's doing in Indiana, I guess.
Thank you. Thank you very much. I'm Elizabeth Van Ostren, and I'm here today on behalf of my colleagues at both Temple and the University of Pittsburgh, Alyssa Johnston, Mark Roberts, Steve Albert, and Janine Buchanich. And thank you very much for the opportunity to be here. So our study explored whether there's an association between participation in a treatment court program and health outcomes. So treatment court is a global term for a variety of courts, like veteran treatment courts, adult drug courts, mental health courts, that are based in the theory of therapeutic justice and embrace a philosophy that law can improve health and societal outcomes. Next slide. I'd like to thank the CDC for funding our study, but the contents of the paper and my presentation are my own. Next slide. So our study took place in Indiana, and our study population were people in Indiana who were eligible for one of 30 treatment court programs who were arrested for substance use or substance use related crimes like selling substances or offenses committed because they needed money to purchase substances. Indiana was selected as for our study for 3 reasons. First, it consistently places in the top half of states for substance-related fatalities. And this map shows the age-adjusted overdose mortality rates in each of Indiana's counties. The warmer the color, the higher the fatality rate. Second, Indiana has a significant number and variety of treatment courts, which are indicated on this map by the colored icons. And third, it has a governmentally sponsored data warehouse called the Management Performance Hub, which provides access and linkages to data sets spanning across multiple subject areas. Next slide, please. From court records, we were able to identify 530 people who were eligible to participate in one of our 30 collaborative courts. Of those 530 people, 350 participated in and completed treatment court programs, and 180 were eligible to participate in treatment court, but for some reason chose not to enter one. The court records also provided us with sociodemographic characteristics of both groups. Next slide. Using legal epidemiological methods that are described in our paper, we created legal data sets from 3 sources. We received permission from the Indiana Professional Licensure Agency to obtain data from Indiana's prescription drug monitoring program that revealed the prescriptions that both treatment court participants and non-participants were provided with. We identified non-pharmaceutical services, therapies, and programs that were offered to treatment court participants from qualitative interviews of court personnel and court guidance documents. Next slide. So we followed treatment court participants a year after they completed their treatment court programs and non-participants for a year after they decided not to participate in treatment court. And we looked at 3 health outcomes for the groups, those being EMS calls, emergency department visits, and death data. Next slide. We were unable to I'm sorry, let me backstep. So from all of these sources, we created de-identified profiles of 530 people, and we knew which treatment court they were eligible to participate in, what their sociodemographic profiles were like, what prescriptions for pharmaceuticals they received, what other therapies treatment court participants were offered by specific treatment courts, and what happened to treatment court participants and non-participants for a 1-year period after their programs. Next slide. So we were unable to point to a specific intervention or a cocktail of interventions that were associated with health outcomes, but we were really surprised with what we did find. The treatment cohort participants had profiles that were much more likely to put them at risk for poor health outcomes than the non-participant groups. They were more than twice as likely to have a history of a disability, more than twice as likely to be unemployed or have a diagnosed substance use disorder than the non-participant group. Each of those characteristics is associated with a higher likelihood of poor health outcomes. Yet the treatment cohort participants fared much better than those who were eligible for treatment cohort and did not participate. In fact, they were 34% less likely to present at an emergency department, 40% less likely to use EMS, resulting in the administration of naloxone, 74% less likely to use EMS for a substance use related issue, 83% less likely to die, and 83% less likely to use EMS for any other situation. Next slide. So there are a lot of questions that are still outstanding and a lot more work to be done, but our study's results support the importance of treatment cohort as a public health intervention, and we hope that our results can be used to support the expansion of treatment cohorts in communities that continue to arrest individuals for substance use and substance use related crimes. Thank you, and now I'll pass it over to Megan Perry.
Thank you very much, Elizabeth. My name's Megan Perry. I'm a person who has had a problematic relationship with substances, and I design programs and provide education in the behavioral health field. Go to the next slide. So I am grateful to Health Affairs. We've been talking a lot about people without those people today. And so I am grateful that Health Affairs has the Narrative Matters part of this journal, and I'm glad to be here to speak about it. My daughter was born and conceived into trauma, a lack of safety and security, a lot of chaos, and definitely a lot of fear. And a lot of that was caused by my own challenges with substance use and the trauma that I had had in the past. But a lot more of it was caused by the way that substance use is criminalized and the way that stigma affected the care that we both received from providers. So in April of 2001, I was in jail on felony charges for selling $40 worth of heroin. I had been on methadone for 2 years, and I had not used substances in 6 months, and I was 5 months pregnant. And every day the nurse from the methadone clinic would come and bring my methadone to me and in the unit, and she would meet me in the middle of the women's unit, and she would not look at my face. She would only look at the badge on my chest to make sure I was the right inmate before she handed me the bottle. I, however, did look at her face, and on her face I saw the disdain, the disrespect, the disgust, and certainly no dignity. Next slide, please. 4 months later, my daughter was born, and I had gotten out of treatment, out of incarceration, as I was about to start the drug court program. But while she spent 7 weeks in the hospital being slowly weaned off of methadone using morphine, the doctors and nurses, for the most part, just kind of pushed myself and my husband aside. We did not have a voice in her care. I felt very extraneous and non-essential to the process of her care and her life, and I had a really hard time bonding with her in those first months. When she did finally get home, we didn't really know how to take care of her because we hadn't been given a role or the ability to do that while we were there. I spent the next 18 months in drug court, and I know that Elizabeth just spoke about the outcomes from that. For some of those participants, my experience with drug court is that it brought much more trauma and fear and Being under constant surveillance was very, very challenging. And I was incarcerated many times in the first 18 months of my daughter's life for things like I spent my first Mother's Day in jail for lying. And so I was taken away from her over and over. It did not help us. It just caused more difficulty for us. There were other ways that we could have gotten the care that we needed and support that we needed that was outside of that system. Next slide, please. So I consider myself lucky because I am a white woman. I am an educated woman. I come from a middle-class family. And so the impact of the circumstances that I was in and the systems that I was in was less than it would be had I had a different skin color or less resources or less education. And so there are many people for whom this would have been much, much worse. Like, for instance, I was not reported to child welfare until a little bit later in her life. I also consider myself lucky because this was 25 years ago. And we actually report more parents for substance use during the perinatal period now than we did 25 years ago. So we're reporting more people for using substances, and they may be using those substances for any number of reasons. We haven't really named chronic pain patients in here, but their voices also need to be heard, and there are many parenting people who are using substances for pain, and there are many that are using them that are non-problematic. One of the greatest protective factors that we have for children is that secure attachment in those first months of life. And if we care about the children, we have to care also about the parents. And we have to do everything that we can to address the needs of the parent as well as the baby and try and keep them together. And so, risk reduction paired with comprehensive health care. You can go to the next slide, please. That's me and Sophie today. We turned out okay, but not necessarily because of the systems that we have in place. And so, if we can really focus on, you can move to the next slide, not reporting, not criminalizing, not coercing or forcing treatment, but really seeing the whole full picture of people's lives and why people use substances and what it is they need, and providing comprehensive care that happens under one roof is really, really important. And I'll just say this as a final thing, is that dignity and voice in treatment is essential. Thank you.
Good afternoon, everyone. My name is Andrew Goodman, and I'm speaking to you today as someone who's been navigating access to medication for opiate use disorder in Colorado and at times nationally since 2010. For years, I struggled with heroin addiction, which became this vicious and seemingly endless cycle of use, withdrawal, and relapse. Through countless failed interventions in my late teens and 20s, I internalized the message that my addiction was treatment resistant, and my inability to remain sober through 12-step programs or buprenorphine was my moral failing. Looking back, I recognize that rather than possessing some inherent character flaw or supposed resistance, I had simply never been offered the gold standard treatment for opiate use disorder, that being methadone. After years of spinning my wheels, I was finally connected with methadone while in drug court, and my whole life changed. I sometimes wonder what my 20s could have looked like had this option been considered earlier, avoiding years of trauma and harm. Methadone should be offered as a first-line treatment, not a last resort. With energy and time freed from the constant chase of that next high, I enrolled at the same college on whose campus I had once been trespassed and arrested for using in the bathroom, and went on to graduate with a degree in philosophy. My return to the classroom rekindled an enthusiasm for learning and discovery, wrestling with tensions between the notions of free will and socio-biological determinism, or age-old questions about the good life and the nature of right and wrong. Implicitly or overtly, I connected our classroom exploration to this issue, concluding American drug policy is a paradoxical hamster wheel that perpetuates its own continued failure to provide medication to people with OUD. Scientific evidence is ignored, hard-earned wisdom often neglected, and the scorching stove of prohibition perpetually stoked to ensure it remains hot. In my piece titled My Methadone Journey, the Gold Standard in Frustration, I do my best to quickly outline the link between laws implemented over a century ago and the ongoing epidemic of addiction and despair, all too visible in 2025. Unfortunately, it would take a whole other paper or even a book to track how we got into this mess, with a deeply entrenched, fully illogical system of overregulation plaguing access to life-changing medication. After 10 years on methadone, I would love to continue my treatment due to the stability it provides, but I'm perpetually tempted to stop because of the endless hoops I must navigate. The inability to ensure adequate take-home doses has caused me to miss weddings and funerals, fostering an unproductive sense of guilt. I feel tethered to the physical clinic location, unable to travel for extended periods of time, and limited in where I can move for graduate school. Many clinics prioritize financial interests over patient well-being, with excessive drug testing and counseling requirements seemingly designed to maximize billing rather than support recovery. As part of my job at Denver's Public Health Department, I often meet individuals who would likely benefit significantly from methadone maintenance treatment. Regrettably, its well-earned reputation as liquid handcuffs causes would-be success stories from seeing this well-established, efficacious intervention as a viable option. As a demographic often struggling to get out from underneath judicial surveillance, many refuse to submit themselves to undue hardship, excessive supervision, and reduced freedom. An assumption of goodwill or benefit of the doubt is never afforded. Your daily dose is presented as a privilege to be dispensed only after payment, paperwork, diversion checks, call-in lines, camera supervised urine analysis, and so forth. With recent trends signaling a waning overdose crisis from the highs of recent years due to increased availability of naloxone and opioid pharmaceutical settlement funds flowing to local providers, there will be more survivors of fentanyl addiction in need of comprehensive treatment. It's time to lift the barriers to methadone, the gold standard treatment for OUD. That's all. I'm happy to answer any questions. Thank you.
Thanks, everyone. These are really incredibly interesting presentations, and to me really speak to how important it is to have a combination of really some numbers and quantitative data to understand the circumstances around treatment and the intersection with criminal justice systems, as well as the influence on access to services among youth, as well as the qualitative research and of course the personal stories that people are willing to share and go through. And I kind of want to start with a question for you, Megan. You didn't talk a lot, you didn't talk about your own organization, which is the Megan Perry Group, but you did tell us a little bit about it in telling your own story. And I was wondering if you were willing to share how you came, maybe just quickly tell us what your organization does, how you came to that, and maybe how it would have helped you to be able to share your story earlier on and as you were encountering a lot of these unhelpful experiences and systems.
Yeah, thank you. I love that question. So at Megan Perry Group, we do what I wished I had, which is things that are outside of the traditional systems and that are arts-based and community-based and peer-led. And so we really amplify community voices and the both lived and living experience of people in the systems. And I came to that because I felt like I didn't have a voice in treatment, and I had, incredible number of treatment episodes. I've been on all of the MOUDs, was in trials for buprenorphine in 1999. I've been in these systems for a long time, and I found that I was sort of trapped in a very stigmatizing way of telling my own story because I was not exposed to anything different. And so over the years, I've learned through a lot of, over a decade of advocacy that we can tell our stories and talk about our experiences in much less stigmatizing ways, and that give us agency and give us dignity. And so that is the main focus of what I do, so that we're not just talking about people, but we're talking with people, and that those people are talking about themselves and their own communities.
Thanks. Yeah, it's really an amazing organization just from having looked it up a little bit. So I encourage others to check it out as well. And that brings me to a question to Andrew. I know you and I have talked a little bit offline also about this experience of kind of having your story published in a special issue like this of Health Affairs. And I'm hoping you could tell us a little bit about what that experience was like to even have the opportunity, get it published as someone who's kind of new to research and writing in this kind of platform, and what it might mean for doing this more in our kind of health research and policy work around substance use.
Yeah, thank you for your question. I need to acknowledge my National Coalition to Liberate Methadone colleagues, Kate Roberts and Dr. Hanan Braun, who kind of pushed me to submit in the first place. I don't know if I would have without them telling me that narrative matters is a piece of this and they want to hear from people with lived experience. I think that being included in research and writing projects has meant a ton to me and other people with lived experience. Not just extracting our voices and our testimony, which I've seen in other spaces, but treating us like actual experts and staying true to the values of like, nothing about us without us, and those closest to the problem or closest to the solution. But I think that just, finding harm reduction, returning to school, advocacy, the whole research and writing, it's been pivotal for me in reframing how I perceive my addiction and kind of redirecting some of the anger I had internalized outwards onto the system.
Thanks. Yeah, thanks to both of you for being willing to share that. I guess moving on to a couple of other questions I have for some of our panelists. So Eric, you talked really interesting to hear the experience about working with the jails and how they're using telehealth. And I think one of the big gaps that kind of came through in some of these different pieces that touch the criminal justice system and is what happens when people actually leave, even if they have access to treatment when they're behind bars. We know the transition to community care is really complex, and often people don't continue treatment. So wondering kind of what you learned from some of the jails in terms of if they were using telehealth to connect people, especially people living in rural areas, to providers in the community, and what kind of you saw worked better or worse in that respect from your work in Maryland.
Yeah, thanks. I have to acknowledge, first of all, that Maryland is not Wyoming or Montana, so we have some resource. We're a much smaller state. But one of the things that we learned was it was really a critical from day one to start looking. We had a team on the ground. The team at the jail varied, but sometimes it was actually the correctional officers that would help engage folks and look for outpatient care upon release. And I understand that medicines are just part of the process of getting people well, but it's an important part. So day one, I learned too many times, like somebody would say, I'll be here for 3 months. And the next thing I knew, he was released. So that was really important. We actually are doing some studies now on injectable buprenorphine as well to see if that might be an easier way to transition people into the community. We also write bridge prescriptions for patients. So if somebody were to leave and it took them 2 to 3 weeks to get an appointment, I will go ahead and call the pharmacy and make sure they have medicines to make until they can get an appointment, and we can continue to do that. So those were some of the things that we looked at, and different counties had different levels of resources. So we worked hard to uncover who would provide treatment for our patients when they left.
Thanks. Elizabeth, I wanted to ask you a methodological question. So you talked really interesting to kind of see comparative effects of being in the treatment court programs that you mentioned, and just knowing that the kind of the treatment court, specialty court landscape is very complex and people have very mixed experiences with it, as Megan mentioned as well. Kind of there's pros and cons. And I think one question in terms of the research in this area is really it's very difficult to compare people who participate and don't participate in these programs, both in terms of who's eligible and who's not eligible, and also who ultimately decides and where those decisions are coming from. Is it because it has to do with the charges and whether it's worth being in the program, or other reasons that we can't really quantify? So I was wondering what you can kind of tell us in terms of how you all thought about this or continue to think about this in your work, so that we can really understand what the effects of these programs are and disentangle a lot of the kind of selection biases into these programs that we do see.
Sure, and let me start by saying that neither myself nor my team advocates for judicial involvement for people with substance use disorder. That is, we fully recognize that, you know, even the mere act of being arrested is very traumatic and detrimental. So I just wanted to put that out there. But we as a society have continued to arrest people for substance use. And so that's kind of the lens that we were looking at our research study through. It would be a great next project to do a qualitative component and to interview both treatment court participants and those who were eligible. And I think that might have been lost a little bit in my talk. So each of these treatment courts have different eligibility requirements. Unlike other types of courts, you have to actually apply to participate in a treatment court program. So all of the people that we studied, all 530 people, were eligible for treatment court program. They had been accepted. So there are a number of confounding variables, but at least at the time these folks applied for treatment court, there's an assumption that they actually wanted to go. And a great next step would be to find out why they didn't, you know, and that would be a qualitative piece.
Thank you. And I know we're running a little bit short on time, but Sarah, I just wanted to throw a last question at you. You mentioned methadone, and it might be too early in your studies to see this, but wondering whether you've seen any effects in your data on the new changes that SAMHSA established around no longer needing kind of prior failed attempts to enter treatment with methadone when it comes to adolescents, or if you're looking into that maybe in future research.
Yeah, thanks I think it's probably early to say. I think I will sort of share my like clinical experience, and then just is that it has continued to be really difficult to sort of think about under 18-year-olds being able to access methadone treatment. And I think that's in part because it takes probably a long time to sort of shift our views on sort of like what is appropriate care. I think often too, opioid treatment programs are really designed and developed for adults. And actually a lot of even the young adults I take care of do not find them to be like settings that are sort of right for sort of who they are as young adults, developing and figuring out their identity, not wanting to be, you know, they don't want to be like, I guess, like reduced to their disorder too. Like it's like there are other things. And so sort of thinking about other creative settings where the medical care, like in receiving methadone is a part of it, but not all of it, I think is really important. And I guess as we even, you know, one of the struggles in taking care of youth is like the numbers are going to be smaller. They're always going to be smaller. And that doesn't mean that it's not totally imperative that we ensure that they have access to all of the same evidence-based treatments that adults have. And so sort of as we think about, sort of access to methadone, what does access to methadone really look like for adolescents and young adults? And including people who take care of adolescents and young adults, but also the young people themselves, and sort of like helping to tell us like what these programs, you know, what programs and access to care really can look like. I think it's like a way to be thinking about what happens next.
Thanks. Yeah, and I think that's a great point to end on. I will now pass it back to Don Metz for closing remarks, but thank you so much to our amazing panelists and your work on these papers. Look forward to reading them more in depth.
Yes, thank you. Thank you, everybody. Really wonderful presentations. I do want to thank our moderators for keeping us moving and being mindful of the time. Also, of course, our panelists for presenting their work and perspectives today. I especially want to thank Kaya Renouf, Carrie Fisher, Megan Perry, and Andrew Goodman for sharing their personal stories and experiences and for humanizing these issues. We really appreciate that. And of course, thank you to everyone who attended the session today. I have a couple of announcements, but just want to quickly address one thing really quickly that Megan Perry touched on, and that is the question surrounding how to balance the need to treat pain with the need to prevent dependence, and in general, the complications surrounding separating opioid use from problematic substance use. These are really important questions, but not directly addressed in our issue. We would certainly welcome more papers on these topics. Just quickly onto the announcements. We hope you'll join us for some upcoming events on September 17 from 2 to 3 p.m. Eastern Time. We will host a virtual event featuring Josh Sharfstein of the Johns Hopkins University and Brendan Saloner of Brown University, who's here today, for further discussion on the opioid crisis. And this event is open to the public. On September 23 from 1 to 2 p.m. Eastern Time, we will host a virtual event exploring the current state of prior authorization. This will be moderated by Mark Fendrick of the University of Michigan. This event is exclusive to members of Health Affairs Insider Program. And just want to note, a recording of today's event will be made available on our website, healthaffairs.org. Thank you again to our panelists and our audience. Really appreciate it. We are adjourned. Thank you.